This conference will now be recorded.
Bismillahirrahmanirrahim. This is my revision session as a part of the crash course MRCOG Part 2 for February 2020. I will be happy to thank all my friends. Really, you are lucky to have all these mentors to help you, like Ghada Badran, Ahmed Al-Agami, Al-Gharyani, Magid, all these mentors. You have a lot of knowledge in a short period of time. Really, you are lucky. We didn't find anyone to help us before our exam. We suffered by our own. Our target is to pass next week. Inshallah, all of you will do it. MRCOG Part 2 crash course. Final revision for February 2020 group. I will give an exam tips and tricks. It will be fast because I have no time for you. Your time is, I know that you all of your time is precious now. So I will go fast. If you have a question, make it at the end, please. All the best for you. If I passed, definitely all of you will pass. And I will give you a lot of knowledge today. So you will be at the same level of the MRCOG Part 2 candidate or an ST5 to pass this exam. I like this studies. Our success is loading now. Today is 29 January 2020. Only 7 days, and your dreams become true. I know that cervical screening have a lot of issue and have a lot of dictate in the last few days. So I will discuss it first, then I will focus on the most hazy points in the MRCOG Part 2 syllabus. By the end, I will give you all the chance to discuss. The NHS cervical screening program starts at 25 years old. Any woman by the age of 24.5 will receive an invitation. This invitation, she will receive it at her birthday, 25th years old. From 25 years old up to less than 50, 49, she will come for the routine recall every 3 years. After that, she will be for the routine recall after 5 years, every 5 years. So this is the NHS cervical screening program. There is a new good practice technique released by the start of 2019. I will touch it after the basic one 2016, and I will tell you what is the difference and how to play and what is the tricks. Okay, so this is how to start. I did a long session for cervical screening. It will be, you will find it on the YouTube. This is not for the one who is going for the exam. If anybody wants to know more about this, he will go for the YouTube channel. He can find a 4 hours discussion about the cervical screening. So, as we know, this is the old protocol. The old protocol depends mainly on cytology triage, as I said before. After that, human papillomavirus triage. So 2 levels was before. Cytology screening by liquid-based cytology. After that, human papillomavirus screening. It was the second screening, and the first screening was the cytology. After that, the test of cure. This was the 3 triage or the 3 levels of the screening. It should change it now. There is a good practice from the RCOG. It was since 1 year, and now the NHS changes it to screen the patient by the human papillomavirus triage first. Okay, so let's revise our previous protocol, then we will go for the new protocol. Okay. The first line, voice is interrupting.
Clear? No, it's clear, sir. It's clear, doctor.
Someone is writing no voice. So if you find, please, if you find any interruption, please stop me. Okay. So the first screening at 2016 released from the NHS was the first cytology triage. The cytology triage, there is a rules, and all of you know the rules. Inadequate cytology, you will repeat it after 3 months. High grade cytology, you will go for colposcopy without doing the human papilloma virus. So this I will tell you the clues or the rules. Inadequate cytology, repeat after 3 months. High-grade dyskaryosis, go for colposcopy without doing the second step, human papilloma virus triage. Borderline squamous, endocervical, low-grade dyskaryosis, here I will do the human papilloma virus triage. Any glandular dysplasia or any patient have a non-cervical lesion, means coming from the endometrial, this will be in the routine recall. Any patient having a borderline squamous or borderline endocervical or low-grade dyskaryosis, I will go for the second screening test or the second level of screening, which is the human papilloma virus. Human papilloma virus positive, refer to colposcopy. Human papilloma virus here, test is inadequate or unreliable with low-grade dyskaryosis, refer to colposcopy. So these are the colposcopy rule. High-grade dyskaryosis from the start without human papilloma virus, I will go for colposcopy. Positive human papilloma virus after borderline cytology or borderline squamous or borderline endocervical, a positive cytology or a positive human papilloma virus, I will go for colposcopy. Inadequate with low-grade dyskaryosis, I will go for colposcopy. Human papilloma virus negative, routine recall, and this will be continuous with us. They will not release the new protocol. They will not release any woman unless she is human papilloma virus negative. Any woman human papilloma virus positive will be under the screening protocol. So this is a trick about the new one. Human papilloma virus positive, go for colposcopy. Low-grade dyskaryosis, inadequate human papilloma virus, go for colposcopy. The only situation here, if you have a human papilloma virus inadequate or unreliable with borderline cytology, again, you will go for the third level of screening. You will repeat again after all this, you will repeat cytology and low-grade dyskaryosis, human papilloma virus, you repeat both of them after 6 months. So if you find one of these, the exam question will come like this. The patient have borderline squamous or endocervical and low-grade dyskaryosis. So you will go for human papilloma virus positive. Human papilloma virus positive, go for colposcopy. Inadequate with low-grade, go for colposcopy. Inadequate, unreliable with borderline, you will repeat. After what? After 6 months. You will repeat what? You will repeat both cytology and human papilloma virus. Okay? After repeating, again, you will go for the triage. Any high cytology, the same like here, I will refer for colposcopy. Human papilloma virus positive, again, like here, I will go for colposcopy and negative routine recall. Any question before I move? This was the old screening. And until now, it's valid. Why? Because the new screening is not mandatory in all trusts in UK. Until now, the old screening is still working. So this was the screening program. The screening program, the first level here, cytology. The second level here was human papilloma virus and test of cure after 6 months. Okay? If a woman is untreated, means she's having a CIN1. In CIN1, the NHS prefers in a young woman in her 30s. Why? Because she will get pregnant, not to have a treatment, because the treatment will do what? Will impair with her fertility wishes. Next pregnancy, she will have a problem, a preterm labor, she will have a preterm birth, she will have a risk of rupture of membrane. So the NHS prefers in a CIN1 to follow the yearly follow-up protocol. Don't do leads for a young woman.
Doctor, one screen is actually, excuse me, one screen is actually appearing in your screen. Somebody is sharing his screen. Can you please remove the screen from?
A screen is opened. A camera. Just a second, please.
Nothing, no other screen.
No cameras open, my dear. Please take care about
Yes,
your
sir.
cameras because it will be on public and this session is recorded. Take care, please, from your camera.
Someone is opening his camera.
Yes, sir. Somebody is opening the camera. So your
I
screen
checked,
is halfway only we could see. It's not full screen.
I checked it now. No, nobody opening the camera. If it happens again, please inform me to close the camera.
This is my, yes, sir. It is open.
Still open.
It is still it
He
is
has
still
covered
open.
It is still open, so we cannot see the
Still
full
open.
screen of. Can you please remove from your side, because who is opening, he is not removing that one.
The screen is clear. You should remove from your own side.
Yes, sir. It is fine now.
Nobody
removed,
opening
sir.
Okay.
Yeah, it's okay, sir. Now it's okay.
Okay. Please all try to take care about your camera. This session will be on YouTube. Okay, let's go again. So the NHS prefers for a young woman in her 30s not to do treatment for CIN1. They will go for yearly follow-up of the patient every 12 months. Why? Because the treatment will affect her fertility. That's why they are going for the yearly follow-up. So in a CIN1, preferred to follow the patient. 50% of the CIN1 will resolve in about 22 months, as I remember. Okay, so the NHS prefers to do what? To do yearly follow-up for a CIN1. Then what you will do? Untreated histology or confirmed CIN1, you will do a follow-up after 1 month. Again, you will follow our rules. Low-grade dyskaryosis, human papillomavirus negative, you will inadequate, you will repeat after 3 months. A high-grade dyskaryosis, you will not do human papillomavirus, you will go for colposcopy. Low-grade dyskaryosis and human papillomavirus positive, you will go for colposcopy. The same rules, inadequate, 3 months, high-grade colposcopy, low-grade with human papillomavirus colposcopy. So these are the same rules. A yearly follow-up, if you find cytology negative and no human papillomavirus is fine there, go for another year follow-up. Again, if you find negative, put the patient on routine recall. Why routine recall? Because I didn't do any treatment. So yearly follow-up, both negative, routine recall. And take care why I am saying routine recall. There is no treatment done here, only follow-up. Untreated CIN, yearly follow-up, both negative, routine recall. If untreated CIN, you will find, again, you find a cytology borderline, human papillomavirus negative, go for 3 years recall. Okay, this will be the tricks of untreated CIN. Treated CIN, the trick is test of cure after 6 months. What is the test of cure? I will do both cytology and human papillomavirus. If I did a treatment, there is no routine recall, a 3-year recall. So if I did a follow-up, it will be yearly follow-up, after that routine recall. If I did treatment, test of cure will be after 6 months, then a 3 years recall, no routine recall after a treatment. So what will be the result in the test of cure? According again our rules, cytology negative, Human papillomavirus inadequate, 3 months. High-grade dyskaryosis, go for colposcopy without doing human papillomavirus. If you find cytology borderline or low-grade dyskaryosis and human papillomavirus positive, you will go for colposcopy. And if you find both negative, cytology negative, low-grade dyskaryosis, human papillomavirus negative, 3 years recall, no routine recall. If you did a treatment, so test of cure after 6 months, then if post negative, 3 years recall. Remember this, there is no routine recall. If the woman aged more than 50, you will bring her again after 3 years. Okay? Until now, we are fine. So let's move for the difficult chart. The difficult chart will be the CGIN. If you find CGIN in the sample, then remember there is 2 tests of cure. One at 6 months and one after 12 months. Means 12 months from the first and 18 from the treatment. So if you find CGIN in the sample, there is 2 tests of cure, 6 and 12. 12 from what? 12 from the first test of cure, 18 months from the treatment. Okay? And the result will be according to our rule. CGIN in the sample, you will do the first test of cure 6 months after the treatment. Human papillomavirus inadequate, go for 3 months, repeat after 3 months. Cytology negative, human papillomavirus positive, go for colposcopy. High-grade dyskaryosis, go for colposcopy. If you find cytology negative and human papillomavirus negative, you will not discharge the patient. You will call the patient for the second test of cure after 12 months. Cytology negative, human papillomavirus positive, colposcopy referral if it is not done because human papillomavirus positive. Negative, if post negative colposcopy, repeat again at 12 months. Don't discharge the patient. This is the second test of cure. Okay, what you will do? Test of cure with or without colposcopy. This what means according to the local protocol in your hospital, you can do any one. You can do test of cure or colposcopy. I have colposcopy in my hospital. I will repeat colposcopy. If you did colposcopy, repeat colposcopy. And this is a trick in the exam because he may put this for you. If you did test of cure at 6 months, repeat test of cure at 12 months, the second test of cure. If you did colposcopy, repeat colposcopy. So again, if you find CGIN in the sample, you remember 2 tests of cure. Test of cure at 6 months and test of cure at 12 months. After that, a 3 years recall. And the other is the same. You will go in this direction. Always exam question coming here. A CGIN.
Sir, could you please repeat it again?
Okay. A CGIN in the sample means second 2 tests of cure. 2 tests of cure. CGIN of the sample, 2 tests of cure. 6 months and 12 months. 12 months from the first one and 18 from the treatment. What you will do? You will do colposcopy or test of cure according to your hospital. If you have test of cure in the hospital, you will do it twice. If you have colposcopy, so you repeat colposcopy. And this will be an exam question. What you will do? You will do test of cure at 6 months. If post negative, you will repeat it again at 12 months. If post negative, you will go for a 3 years recall. No routine recall if you did a treatment. And this is a high CGIN, so no routine recall, a 3 year recall. Even post negative, a 3 years recall. So let's read the chart. It will be after that following the rule. A CGIN, so test of cure after 6 months. After in the result of test of cure, human papillomavirus inadequate, repeat after 3 months. High grade, you will refer the patient for colposcopy. If colposcopy negative and you have no excision, you will continue for the patient for 10-year follow-up. Complete yearly 10 years cytology because this is a CGIN. If you find human papillomavirus positive again, refer for colposcopy. If negative, both human papillomavirus negative, cytology negative, go for the second test of cure. The second test of cure again negative, so 3 years recall. After that, you can release the patient for the restarting or start again the screening program. If you find human papillomavirus positive, if you find human papillomavirus inadequate, cytology negative, go again for 3 months, rescan the patient after 3 months. Cytology negative, human papillomavirus positive, colposcopy referral if not done. If colposcopy negative, repeat after 12 months. Again, if you have cytology abnormal, colposcopy referral if not done. If colposcopy negative and no re-excision, you will complete follow-up for 10 years, because a high-grade CGIN should be followed up for 10 years. Is this chart is clear? Because this is the most difficult chart today.
Hello, Dr. Hani. Can you please explain that re-excision point? What's the relation with the re-excision in CGIN?
You didn't do re-excision and or no re-excision. You didn't treat the patient again. You did negative. You did colposcopy after 6 months or after 1 year, and you find a high grade cytology abnormal, colposcopy referral if you didn't do colposcopy before, negative for colposcopy, and or there is no re-excision. You didn't do re-excision again. You didn't treat the patient again. You will continue to do follow-up for patient yearly for 10 years. Okay?
Okay. Means if we re-excise, then we need not to follow up for 10 years. Like this?
You will again, if you did a treatment, you will do it again, test of cure and 612, and after that you will continue for 10 years more. Any treatment, test of cure, my dear.
Okay, thank you so much.
Okay.
And when we have to re-excise and we don't re-excise, what is the difference?
If you find invasive or progression, you will repeat. I will come for this in a few seconds, please. Just a second, I will come for you for when to do and when not to do. Okay? This is the colposcopy referral, or when to refer the patient. This is the rule. If you find 3 inadequate sample, colposcopy referral within 6 weeks. If you find borderline with human papillomavirus positive, 6 weeks. When to remove, this is the cancer weight, or when to refer the patient. This will be can be an exam question. If you find low-grade dyskaryosis with positive human papillomavirus, all these are low-grade region with no high suspicion. So you will refer the patient in the low-risk triage or in the routine triage or the routine way within 6 weeks. Inadequate, after 3 inadequate sample, you repeat it 3 times. After 3 months, you will find it inadequate. Again, after 3 months, inadequate. Again, after 3 months. So 3 inadequate sample, refer the patient for colposcopy within 6 weeks. If you find borderline change and human papillomavirus positive, refer the patient for colposcopy within 6 weeks. Low-grade dyskaryosis with human papillomavirus positive, refer the patient within 6 weeks. A high suspicion, moderate dyskaryosis, severe dyskaryosis, CGIN or invasive, refer to colposcopy within 2 weeks. Invasive glandular neoplasia, this is outside the NHS, or any abnormal or suspicious cervix, all these outside the NHS cervical screening program, it will be referred to within 2 weeks again, but for gynecology or according to what the patient is suffering from, abnormal cervix, suspicious, anything, it will be referred to gynae or gynecologist within 2 weeks. Okay? So according what you find in the patient, you will refer for colposcopy within 2 weeks or within 6 weeks. The new NHS protocol. It was a good practice before, and the NHS released the new issue. What is the new issue? This is the link if you want to have a look about it. And this is the new screening program. To do a cervical screening program primary by human papillomavirus screening implementation. No cytology start or cytology screening in the first. It will be the high risk human papillomavirus screening implementation. So information to be released for the NHS, it's released about 1 year now for the all trusts in UK, but it is not yet obligatory. Some trusts working by the old NHS program. information to be aid for the local providers of the NHS cervical screening program in implementing the high-risk human papillomavirus testing to start the screening program by the human papillomavirus screening. This is the cervical screening protocol of 2019. First, I will start, instead of doing cytology triage, I will do human papillomavirus. And when I was referring the patient, if I find human papillomavirus positive and cytology abnormal, this is a routine. If I find any cytology abnormal, human papillomavirus positive, I will refer the patient for colposcopy. So no new, just they put the second level as a first level. The high risk human papillomavirus will be the screening first step. If the woman negative for human papillomavirus test, she will be on routine recall. So they will not release the woman from the screening or letting the woman go for routine recall unless she is negative. Remember this trick. If the woman is human papillomavirus negative, she will be in routine recall always. If she is positive, I will not refer for colposcopy before unless the cytology, the second level, became abnormal. Does it make sense? Before, I was doing cytology first. Then, if high-grade cytology, I'm referring to colposcopy. Now, he's doing the high-grade human papillomavirus. If it is negative, put the woman on routine recall. If it is positive, go for the second step, which is the cytology. Cytology negative, rescan or repeat again the human papillomavirus after 12 months. Cytology positive, refer the woman for colposcopy because she have both now a high risk human papillomavirus plus abnormal cytology. It's easier than before. And why they put this? Because the human papillomavirus is low costly to decrease the cost on the NHS. Does it make sense? So you will do a human papillomavirus triage first, negative routine recall, positive go for cytology. Cytology negative rescan after 12 months by the human papillomavirus. Cytology positive refer for colposcopy. If you rescan the patient again, negative, go for routine recall, positive, go for cytology. Cytology negative again, rescan after 12 months by human papillomavirus test. Cytology positive refer for colposcopy, but after 2 years of follow-up, you will refer the patient for colposcopy if it is positive or negative cytology. So if you find the woman is still negative for 2 years, you will refer her for colposcopy, even in human papillomavirus positive cytology or negative, inadequate or abnormal. So the limit here for 2 years. Rescan again after 1 year. If you find human papillomavirus negative, routine recall. If you find human papillomavirus positive with cytology, go for colposcopy. But after 2 years here, take care of from this new trick. After 2 years, and the woman is human papillomavirus negative, routine recall. In human papillomavirus positive, cytology negative or inadequate or abnormal, you will refer the patient for colposcopy. Okay, you will not do rescan again. Does it make sense?
But here, when the human papilloma virus becomes positive, we refer for to the other box, the third line, cytology abnormal. This cytology we repeat again, or we follow the previous one?
Repeat your question, please, again.
Like after rescreen in 12 months, the middle box.
Yes.
Where cytology was negative, then cytology negative. When after 1 year it becomes positive, after that we do cytology again.
If you did again cytology negative, you will rescan the patient here. So if the cytology is cytology negative, you rescan the patient by human papillomavirus. Human papillomavirus positive, After that, you will go for the second step, which is cytology again. Cytology negative, and the patient is.
So after 1 year, if the HPV becomes positive, we will repeat the cytology again.
Yes. Here,
if
cytology,
even it was negative before.
Cytology negative, you will do again human papillomavirus positive. You will go again for the rescan. Rescan means by human papillomavirus. Human papillomavirus positive, cytology negative or inadequate or abnormal, here you will refer the patient for colposcopy. You will not rescan again if cytology negative. This is the difference here, my dear. Okay. After 2 years, even if cytology negative, you will not rescan again. Stop here. This is the trick after 2 years. Okay. I think it's easier than before.
Thank you. Thank you.
Hani, we will follow old one or this one?
It will be in the exam question, my dear. What he starts, you will follow. If he starts cytology, go for the previous chart. If he starts human papillomavirus, go with this one. It's easier. He will tell you a patient came at 35 years old with a human papillomavirus test, came positive. So he didn't start by the screening program, the histology. So he's coming here. So it's easy. Where's the question targeting you? If he asks about the patient screened by human papillomavirus positive, play here. If he asked by cytology, go for our charts. Does it make sense?
Okay, thank you. Thank you.
After that, it will be the same, almost the same thing. When to refer the patient to colposcopy, you will go for the same what you did. If you did colposcopy, you will follow our routine charts. Colposcopy examination, you find it adequate means what? The colposcopy having done normally, and you find a finding in the colposcopy. The colposcopy came a CIN1 or more, you will go for the same management. Less than CIN, again, you will go for human papillomavirus. If it is human papillomavirus positive, cytology low-grade dyskaryosis, 3 years recall. If it is high risk human papillomavirus positive and high-grade dyskaryosis, this is a new trick here to follow the patient after 2 months by a multidisciplinary team or an oncology team. So again, you did a colposcopy and you are happy by the finding. Less than CIN1 or CIN1 or more. CIN abnormal biopsy, CIN1 or colposcopic impression about CIN1 or more, you will go for the treatment, what we said. Okay. If it is less than CIN1, so you will follow up the patient by high risk human papillomavirus. If the high risk human papillomavirus positive and cytology low grade, repeat after 3 months, recall after 3 years, sorry. If you find a high grade cytology or cytology abnormal more than high grade or borderline endocervical, you will discuss it with a multidisciplinary team. If you find inadequate colposcopy and a high grade cytology, do leads. If you find inadequate colposcopy, positive human papillomavirus and high grade dyskaryosis or high grade or borderline ovarian tumor or endocervical, you will do leads. If you find colposcopy inadequate and there is human papillomavirus but low grade dyskaryosis, repeat colposcopy after 12 months. These are the new tricks. I find it is not so different, just they follow the high risk screening program or the high risk human papillomavirus before the cytology triage. Okay.
One more question, please. In the previous one, we repeat leads at some points. Here, there is no option or no situation in which we are repeating leads.
Leave it, my dear. The next slide will be after that. Just a second, please. So after this is the routine, what we are doing. If you find a less than CIN, you will follow up the patient, yearly follow up. After that, if human papillomavirus positive or negative, this is the same. If you look at self, if you look at it and read it, you will find it is the same as before. abnormal colposcopy, CIN biopsy or colposcopic impression. Recall again, there is CIN1 on the biopsy, and you will go for the follow-up. You will not do a treatment. You will go again because I told you the NHS don't want to treat the CIN1 because the high regression rate. That's why they are putting this on the chart. Don't treat CIN1, yearly follow-up. So recall after 1 year, high risk human papillomavirus positive or negative. Even if negative, it will be on 3 years recall. Cytology human papillomavirus positive, cytology negative after 12 months, again yearly follow-up. Cytology abnormal refer to colposcopy, nothing new, yearly follow-up as we said, but they are following the human papillomavirus triage. Again, after 2 years, if you find cytology negative and the patient is human papillomavirus positive, go for repeating again after 12 months, negative routine recall, positive, and you refer the patient for colposcopy. Okay? So this is the same thing. If you did a treatment, test of cure, and according to what you will find, human papillomavirus positive, you will go for colposcopy. Human papillomavirus negative, 3 years recall. Just change from cytology to human papillomavirus, and the same in CGIN, 2 test of cure. Okay, clear? There is no major issue. It's just a change in the screening to decrease the cost. Okay? Happy?
Please, sir, could you repeat this again, please?
This slide? This slide
Yes,
have nothing, my dear. We said that if you find less CIN or less, you will go for yearly follow-up because the NHS stopped to treat CIN1 for a young woman because the fertility issues, because of the next pregnancy. If she gets pregnancy, she will be a high risk for preterm labor or preterm rupture of membrane. So a yearly follow-up. The yearly follow-up will be by human papillomavirus positive or negative. The human papillomavirus negative, routine recall or 3 years recall, human papillomavirus positive, go for cytology. You need abnormal cytology and human papillomavirus present or high risk human papillomavirus to refer the patient for colposcopy. It's not a new issue. It's the same. A high-grade dyskaryosis with human papillomavirus positive, you will go for colposcopy. Just make the second step as a first step. And the same issues. Okay? I keep repeating this slide because this slide always coming in the exam. When to repeat leads and when to discharge the patient from colposcopy to test of cure after 6 months in the community. I told this and I keep telling this for all the previous batches because it's a matter of debate and always come on the exam. If you did a treatment for a woman and you find unclear or uncertain margin, you will not repeat leads. It is not obligatory to repeat leads unless there is an issue. I have 3 issues to repeat leads. A woman age 50 or more, a CGIN in the sample, or invasion. I will not repeat leads if all these are not there. Again, I did a treatment for CIN and I found the margin of the leads is not clear. There is CGIN or CIN in the margin, means the margin is not a healthy tissue. It is not completely removed. This is meant by unclear margin. Does it make sense? So I will not repeat leads unless the woman is 50 years or more or there is CGIN. That's where I will repeat. For Dr. Muhammad or Dr. Ahmed who asks, I will repeat here. If CGIN in the sample, I will repeat leads because the high risk of CGIN. If the patient have micro-invasion, I will repeat leads. So let's read the slide again. Uncertain or unclear margin and repeat excision. A high incidence of recurrence but does not justify to repeat excision, means to repeat leads, unless there is no evidence of CGIN, or there is no evidence of invasion, or there is woman under 50 years old. So if the woman have one of these, I will repeat leads.
Sorry, it's under 50 years or above 50 years of age?
Above 50, I will repeat. Invasion, I will repeat. CGIN, I will repeat. If the woman have no the three, I will not repeat. I will discharge the woman for test of cure in community. If these criteria are met, I will do test of cure in the community. All women, apart from the exception above, after treatment of CIN should be discharged from colposcopy. For what? Test of cure arranged by GP. Again, if I did a treatment and the margin have CIN, not CGIN, I will not repeat leads unless there is CGIN in the sample, or the woman over 50, or there is invasion. Any one of these issues find in the question, I will repeat leads. If the woman have all these three, I will discharge her for the test of cure in the community after 6 months. Does it make sense? Why? Why I am doing this? Because the CIN, it can be either treated or yearly follow-up. The NHS program wants this, wants not to treat the CIN one. Why? Because over 50% of CIN1 lesion will regress about 22 months. That's why I am not doing re-excision. So if the criteria, one of these criteria is there or breached, I will repeat reads. If all are not there, so I will discharge the patient for test of cure in the community. If there is no evidence in the CGIN, there is no invasion, there is woman under 50, I will discharge her in the test of cure after 6 months in the community. Any one of these tricks are in the question, I will repeat leads. Clear? I am keep repeating these slides for the last 2 years because it's persistent coming in the exam.
Doctor, please, you can repeat it. Can I ask you a question? In the exam, in some of the recalls, the option is cone biopsy. So for CGIN, when the cone biopsy is there, should we choose that first, or is it a repeat leads?
I will tell you now. Just give me a second. It will be in the next slides.
Okay.
Again, the exam question, I did leads for a woman who is 45 years old for CIN 2 or 3 and no CGIN in the sample, and you find unclear margin, don't repeat leads. Let her, even the margin is unclear, means you didn't remove the lesion at all. There is some lesion is there still in the patient. Don't repeat leads. Why? Because a high grade of regression or the patient will regress within 2 months. So if you did the leads for a woman who is less than 50 for CIN 1 and 2 or 3, CIN 2 and 3, and no CGIN, don't repeat leads and do test of cure in the community after 6 months. If you find one of these criteria are there in the question, the woman is 50 years or more, there is invasion or CGIN in the sample, you will repeat leads. Clear? Or again, I will repeat.
Yes, clear.
Clear.
Thank you.
Let's move. So this slide is very important and keep coming in the exam because they know it's a matter of dictate and always you will go for repeat leads because the lesion is still there. No, even the lesion is still there, you will not repeat leads unless there is one of these criteria is breached, over 50, invasive or CGIN. You will do leads or discharge the patient for test of cure in the community by her GB after 6 months. Okay. The follow-up after hysterectomy also a matter of debate and always coming in the exam. I did a hysterectomy for a woman because of CIN3 and she have no fertility issue. 65 or 50 woman, 50 years old woman don't have a fertility issue, have CIN3, and I did hysterectomy for her. Still, there is a risk of vaginal intraepithelial neoplasm. Means what? The cuff itself after removing the uterus. Still, there is a risk of vaginal intraepithelial neoplasia about 1 to 4, and invasive vaginal cancer less than 1% if the CIN is present in the sample. So you need to follow up the patient by Volt cytology even after removing the uterus or removing the cervix. So there is no clear evidence that colposcopy increased detection of disease on follow-up. If no CGIN, no CIN in the hysterectomy specimen and woman was on routine recall, no further cytology for the Volt. So you didn't find CIN in the sample, in the hysterectomy. You removed the uterus and no CIN there. And the woman was following the NHS cervical screening program. So you will do what? You will do nothing because no CIN and the woman is following the routine screening for her. You will do nothing. But if the woman don't following the screening and even you didn't find CIN in the sample, you will do a Volt cytology after 6 months only. And this question, it will come in the exam because they know it is difficult. If you find no CIN in the sample and the woman was not in routine recall, you will do Volt after 6 months. Why? Because she was not in the NHS cervical screening program. If she is, you will do nothing. If the patient have escaped or not following the CIN NHS cervical screening program, you will do only Volt smear after 6 months. Okay? If negative, no more. But if you find CIN in the sample, if CIN is present on the sample you removed and completely excised, so you already removed, but there is a risk. Why? Because there is CIN in the sample. Even you removed it, you will do Volt cytology. Why? Because there is risk. There is risk still available for the patient to have vaginal intraepithelial neoplasia. You will do what? You will do Volt cytology 6 and 18. So the question will come here because this is always coming in the exam. You did a hysterectomy for a patient who have CIN1 or you have CIN and you find it completely excised. What you will do? You will do Volt cytology 6 and 18 months. Okay? If you find the CIN not completely excised, incompletely excised, the follow-up will be according to the type of CIN, CIN1 or CIN2 or 3. CIN1, you will do 6 and 12 and 24 months. CIN2 or 3, you will do 6 and 12 and annual cytology for 10 years or 65, whichever later. What does it mean? Which is later? Which is far? Means if the woman came at 60 years old and you did hysterectomy for her and you find CIN2 or 3 in the sample, you should do 6 and 12 months and for 10 years. So you will not discharge her by 65. You will follow up her until the age of 70, above the level of NHS cervical screening program. Why? Because she came late at 60 with CGIN or CIN2 and 3. You will follow up her for 10 years, which is later, whichever later. Does it make sense? I will repeat again. If you did a hysterectomy, still there is a risk of VIN, vaginal intraepithelial neoplasia. Even if you find no CIN in the sample, no CIN after done hysterectomy, and the woman was on routine recall, discharge here. If she is not in routine recall, do test of cure or Volt cytology at 6 months only. If negative, discharge here. Until now, I'm clear. So you did hysterectomy and you didn't find CIN in the sample. Woman on routine recall before, discharge here, no follow-up. If the woman not on routine recall, you will do 6 months Volt cytology to check if there is any problem or no. Negative, discharge here. So this is if you find nothing. Okay? If you find something, there is CIN in the sample, and woman, you find CIN in the sample, if it is completely removed or no. If it is completely removed, you will do 6 and 18. If it is not completely removed, so according to the level CIN1 or CIN2, CIN1 6 and 12, CIN2 6 and 12 and 10 years, which is later, not earlier. Again, no CIN in the sample, and the woman was on routine recall, discharge here. Was not on routine recall, the Volt smear after 6 months. If negative, discharge here. But if you find CIN completely excised, Volt smear or Volt cytology 6 and 18. But if you find unclear margin, incompletely excised in the vagina, so you find there is still lesion, not removed, according to the type of the lesion. If it is CIN1, it will be 6, 12, and 24. If it is CIN2 and 3, it will be 6 and 12 for 10 years, annual for 10 years or up to 65 years. What does it mean? If the woman came at 40 and she have CIN2 or 3 in the sample, and I will remove it, and I found it still unclear margin. So I will follow up here for 6, 12, and 10 years. It will end by 50. So no, I will not finish here by 50. I will keep following here until 65. This is what means by which is later. But if the woman came here at the age of 60, I will follow up here for 10 years. Does it make sense? Am I clear in this point? Which is later. Okay?
Yes.
We can move? Okay. After
Yes,
that,
sir, clear.
the pregnancy. The pregnancy always a problem. If a woman coming to do routine test, don't do it. Defer it to 3 months after pregnancy. Why? Because there is a cervical changes happen during pregnancy. You will find nothing. You will find different. You cannot detect any cervical changes in pregnancy. So if you find a woman coming to routine recall, don't do it. Defer it after 12 weeks or 3 months after pregnancy. Why? Because the cervical changes of the pregnancy. During pregnancy, due to routine recall, defer it after delivery by 3 months. Due to for colposcopy, but colposcopy, if the patient have test or have treatment before, and you are giving her test of cure, and she got pregnant. If she got pregnant, so you need to do colposcopy or test of cure for her. Do it at 12 weeks. Why? In the late first trimester or early second trimester. So after 12 weeks. So if the woman came for test of cure after treatment, you will do it after 12 weeks. Means in the late first trimester or early second trimester. Okay? After cytology showing low-grade dyskaryosis and human papillomavirus triage, go for defer it after pregnancy. Any routine follow-up untreated CIN or treated CIN, defer after delivery. Only if it is treated and her test of cure came in the pregnancy, you will do it in the early second, late first trimester. But as a follow-up of treated CIN 2 or 3 with positive margin, don't delay. Do it as possible, as it's done, because this is a test of cure again. A follow-up of previous abnormal colposcopy, don't delay. A follow-up of CGIN, because of the high risk of CGIN, don't delay. If repeat cytology due to missed or default, or a woman came while she is pregnant, cytology or colposcopy can be considered in this situation. What this means: if you find colposcopic, if you did colposcopy for a woman at 12 weeks or at 13 weeks or 14 weeks, and you find CIN1 or less suspected, repeat the examination 3 months following delivery. You will not treat the patient. Why? Because the risk of bleeding during pregnancy. So if you find CIN1, repeat colposcopy 3 months after pregnancy. Take care, because a lot of candidates don't know what I am saying. Okay? So you did colposcopy at 13 weeks and you find CIN1, don't do anything. Just repeat the colposcopy after 3 months from delivery. If you find CIN2 or 3 in colposcopy at 12 weeks or 13 weeks, you will repeat the colposcopy again. You didn't do a treatment, even CIN1 or 2 or 3, you didn't do a treatment, you will repeat colposcopy. And new tricks appearing. Why? Because the risk of bleeding in pregnancy, CIN2, even CIN3, is suspected in colposcopy at 12 or 13 weeks. Repeat colposcopy again in the end of the second trimester, means at 28 weeks. If the patient now past the 28 weeks, 32 or something like this, so repeat the colposcopy 3 months after delivery, at 12 weeks after delivery. Does it make sense? Am I clear in this point?
Dr. Hani, please repeat it.
Okay. You did a colposcopy, the patient came for test of cure, and you find you did for colposcopy for her at 12 or 13 weeks, and you find CIN1. So you don't treat. Repeat colposcopy 3 months after pregnancy, because you may find regression after pregnancy. After the cervical changes of pregnancy washed, you will find regression for CIN1. That's why you are repeating it after 3 months. If you find CIN2 or 3 even, you will not treat the patient. You will repeat colposcopy again at late second trimester, at the end of the second trimester. So you did colposcopy at 12 or 13 weeks, and you find CIN2 or 3, you will not treat the patient. You will repeat colposcopy at 28 weeks. And most of candidates will treat, will do leads. No. In pregnancy, don't repeat. Just repeat the colposcopy. Don't treat, because the risk of bleeding. If the patient passed the 28 weeks, repeat colposcopy 3 months after delivery, even it is CIN1 or 2 or 3. The option is repeat colposcopy, not to treat.
If it is advanced.
If you find invasive cancer, it will differ here. Invasive cancer is suspected clinically or colposcopy, a biopsy adequate to make the diagnosis 100%. What you will do, you will do cone biopsy, wedge biopsy, or diathermy lobe leads, or are associated with the risk of hemorrhage. And such biopsy should be taken only where you can stop the hemorrhage. A rich cervix, bunch biopsy suggesting CIN only cannot exclude invasion. So bunch biopsy is not an option in pregnancy. So the only thing, if you find invasive disease is suspected clinically or colposcopy, a biopsy is adequate to make the diagnosis essential 100%. It should be cone, wedge, or diathermy lobe excision or diathermy lobe biopsy, or associated with the risk of bleeding, and such biopsy should be taken only when you can stop the bleeding. In appropriate facilities to deal with hemorrhage are available. Am I clear so far? No treatment for CIN1.
Please explain the previous slide.
The previous slide, I will give you the PDF. I will give you the file, and I will put the session on YouTube. Okay. So I gave you all the issues. Only 1 or 2 points are there. If the patient have HIV, you will follow up here by yearly smear. If the patient have cytology at the diagnosis and at the start of the treatment. If the patient have renal immunosuppressive, these are the remaining point. I don't want to give you a lot of knowledge, just I am giving you the exam tricks. Let's do...
excuse me, sir. I'm very sorry to disturb you. Please, I need a glimpse of the previous slide for 5 seconds, please.
The previous slide only when to defer and when to do. If it is a routine recall, defer here after pregnancy for 3 months. If you have a colposcopy or test of cure, do it at 12 months. After that, if you find CIN or CIN1 or 2 or 3, you will not treat. You will go for the next slide. You will repeat colposcopy. Where? At 28 weeks. And even a lot of candidates don't know this. Okay?
Thank you so much, sir.
So if you did colposcopy at 12 weeks, you will not treat for CIN1 or CIN2 or 3. The only option, my dear, in pregnancy to repeat colposcopy at 28 weeks or 3 months after pregnancy, because the risk of bleeding. So let's play another trick, and you all requests about the POP-Q. The POP-Q, I will make it very easy for you. It is an easy marks in the exam. A POP-Q made easy. What is the POP-Q? The POP-Q is a standardized evaluation system for the woman, for the genital tract, for the prolapse, a pelvic organ prolapse quantification system. I have 3 points on the anterior wall and 3 points on the posterior wall. Point 1 is A anterior, and point B anterior is the remaining part. This is anterior wall. Just a second. I will go for the jam jar. I was in Leeds once a day in Leeds University, and one of the consultants there tells me a very nice trick about the POP-Q. He gave me a jam jar or an inverted cup and told me to teach a candidate what is the POP-Q. I looked for the jam jar and I imagined it as a vagina. The jam jar here is a vagina. This is the cuff after hysterectomy, and this is the anterior wall, and this is the posterior wall. And here is the hymen. Okay? And after that, I put the point of the POP-Q. This is the anterior wall. There is point A anteriorly, which is far from the hymen by 3 centimeters. And this is point A posteriorly, which is the same level, 3 centimeters from the hymen. So this is the vagina after removing of the uterus. This is the cuff here. And this is the hymen. And this is the anterior wall. And this is the posterior wall. Point A anteriorly, 3 centimeters from the hymen. Point A posteriorly is 3 centimeters from the hymen. The remaining part in the anterior wall is called point B anteriorly. The remaining part after that point called point B anteriorly, and the same in the posterior wall, point B posteriorly. So these are the points, and how I will put this point, and what's the benefit of this point. Okay, so I have 3 points in the anterior wall and 3 points in the posterior wall. Point A anterior and posteriorly, 3 centimeters from the hymen, and point B is the remaining part of the vagina, anterior and posterior. Point C for the cervix and the cuff. Point D for the Douglas pouch. It is removed in hysterectomy. You will not find it in hysterectomized patient. Okay. So again, let's go for the previous slide. The pelvic organ prolapse quantification system exam is used to quantify or describe the pelvic support. There is 6 points measured at the vagina to respect to the hymen or in relation to the hymen. Here, 3 points anteriorly and 3 points posteriorly. The 3 points is point A anteriorly, 3 centimeters from the hymen, and point A posteriorly, 3 centimeters from the hymen. Point B anteriorly, the remaining part. Point B posteriorly, the remaining part. The cervix and the Douglas pouch. If you remove this, you will be a cuff only. So no D in hysterectomized patient. Points above the hymen are negative. Why? Because it is above the hymen. So any point above the hymen, I will give it a negative number. So both point here at -3. Point A at -3 above the hymen, mean 3 centimeters higher than the hymen. So all the points above the hymen are negative numbers. Points below the hymen will be a positive number. So -1, -2, -3, -4, 5, 6 until 8. Okay? So the landmark is the hymen. All measurement except the total vaginal length should be measured as Valsalva. Why? Because if you tell the patient to push, the point will descend, so the patient have prolapse. So before taking the distance, you will tell the patient to squeeze or make a Valsalva to give attention, okay, for the woman to give her pressure. If there is prolapse, it will appear. If you have a prolapse or you're suspecting prolapse, you should examine the woman in the 3 position. What is the 3 position? You will examine her in lithotomy to look for the posterior wall. You will examine her in SIMS to look for the anterior wall. You will examine her while she is standing to look for the apical or the vault prolapse. If you find any woman complaining from a bulge in the vagina, you should examine her in a 3 position. What is the 3 position? Lithotomy to look for the posterior wall, SIMS to look for the anterior wall prolapse, squatting position or standing position, and you will be under here to check the vault prolapse. Does it make sense? I made it clear until now?
Yes.
Yes, very clear.
Okay. So, what is the range of movement of this point? Point 3, point A anteriorly or posteriorly, it is 3 centimeters above the hymen. She have a range of movement to 3 centimeters below the hymen. If this point is prolapsed, it will be prolapsed until here only. There is no length more than this, 3 centimeters above and 3 centimeters below. This is the maximum limit of point A to protrude from the vagina. And this is what meant here by the range of movement. Anterior vaginal wall in point A, it is 3 centimeters proximal to the hymen, means -3, and can be prolapsed to +3. This is meant by the range of movement or the range of value. Does it make sense? Also for the same point anteriorly higher than 3 centimeters can be prolapsed more than 3 centimeters until point C, which is at 8 centimeters, can be prolapsed up to +8. The point A posteriorly, most distal portion, and the remaining part of the anterior wall, as we said, anterior and posterior. Point C for the cuff or the cervix, point D for the Douglas pouch, point B and AB for the posterior vaginal wall, point BB for the remaining part in the posterior vaginal wall. This is the point, and this is the maximum range of prolapse. So this is the basis of the POPQ. Another shape for the exam question. He will give you the point by number. What's the problem? I know where is this point now. Point A anteriorly should be at -3, so it is in place. Point P anteriorly should be higher than -3, -4, 5, or 6. Okay, it should be higher than -3. Point C is the cervix to be in place. It will be -7 or -8. Clear? The genital hiatus, it should be about 2 to 3 centimeter. If anything protruded, it will be more than 4 centimeter. Means a dilatation because a bulge is coming from it. The perineum body, it will be 2 to 3 here. The perineum body, 2 to 3 centimeter. If there is a bulge, it will decrease. It will be about 2 centimeter or 1.5 centimeter. That's why the perineum deficient. The total vaginal length is the total vaginal length from the hymen to the Douglas pouch. It should be 8 centimeter, 7 in the anterior wall or 9 in the posterior wall. Anyway, it is a measurement. So the genital hiatus 3 to 4 centimeters, the perineal body 3 centimeter. If it is increased here, means dilatation because of prolapse. If it is decreased here, means deficiency perineal body because of prolapse. Total vaginal length is the length from the hymen to the Douglas pouch. Point P and point A posteriorly, it should be at -3. The remaining part, it should be higher than -3. Douglas pouch, it should be at -9 or -8. Any difference, I said? Nothing. Just another figure of the POPQ by points or by number. Am I clear until now?
For Douglas, what you mentioned, how much Douglas?
Posterior fornix, the total vaginal length. Point D, it will be removed in Douglas pouch. If you did hysterectomy, there will no point D. It should be at the total vaginal length -9.
Okay, thank you.
So these
Genital hiatus. What is the number of genital hiatus?
It should be about 3 centimeter. If it is enlarged, means a prolapse. Make it 4 or 5 centimeter. Dilatation of the genital hiatus. The genital hiatus is the opening of the urethra and the part of the urethra between the urethra and the vagina. If there is a protrusion, it will be increased. Okay? Will be dilated.
Excuse me, Dr. Hari. Excuse me. Please, can you repeat these figures again? Okay.
It's just only put the point in place. So point A anteriorly, it is -3. As we said, point A posteriorly, it is at -3. Point B anteriorly higher than -3. So -4, -5, -6 to be in her place, not discharged. Point C or the cervix, it should be at -7 because -7 or -8 because the anterior vaginal wall approximately is 7 centimeter and the posterior vaginal wall because the posterior fornix approximately it is 9 centimeter. Okay, so all these points to be in place, it should be by -3 for point A, the same level, -4, 5, 6 for point B, -6 or -7 and -8 for point C and D. These are the points, the 3 points in the anterior wall and the 3 points in the posterior wall. The jam jar, my dear. Remember the jam jar, okay? And the genital hiatus, all of us know what is the genital hiatus. It will be 3 centimeter. If it is dilated, means a prolapse. He will give you 4 or 5 centimeter, means something coming protruded from the vagina, making it dilated. Perineal body will be deficient if the patient have a prolapse. Total vaginal length is the length between the hymen and the Douglas pouch or the posterior fornix. These are the normal number for a normal woman, for a normal POPQ quantification system. Okay?
Okay,
so
thank you,
let's
Dr. Hani.
go.
My question
Okay,
is how to
let's
measure
go. Yes?
how to measure these lengths with the help of a finger or with some caliper or what else? How to measure?
It's a rough measurement, my dear. This is another thing. To measure, you will do a BV and you measure your finger on a scale. If you want to know the distance, or you put a pessary, you will do like this. This is your finger here. This is the middle finger. I'm very bad at drawing. This is the index, and this is the middle finger, and this is the posterior fornix. You will put your finger in the posterior fornix, and you will see the symphysis pubis here, and you will see what is the length, and you will measure this. To take the estimated length, it will be like this. But we know already that the anterior vaginal wall is 7 centimeter, and the posterior vaginal wall is 9 centimeter. So let's go for the stages. Stage 0, stage 1, stage 2, 3, and 4. These are the stages or the grades of prolapse. Stage 0, everything in place, or the C or D, the cuff or the Douglas pouch descends to the level of -6, means total vaginal level, total vaginal length -2, but by minus, means from 8 to -6. I will come for this within a second. Leave it now. This is the stages. As we said, the hymen will be the landmark. The total vaginal length to be in place, let's say it -8. Okay? The length here will be 8 centimeter by minus, because it is higher than the hymen. Stage 0, everything in place, or point B, point C, or point D came less than the total vaginal length by 2 centimeters. So it will be total vaginal length -2. It came here. Until now, it's stage 0, no treatment. If these points became lower than this, it will be stage 1. Means until 1 centimeter higher or 1 centimeter below, this is stage 2. If the prolapsed part higher than the hymen by more than 1 centimeter, it is stage 1. If the prolapsed part around the hymen 1 centimeter above or 1 centimeter below, it's stage 2. More than 1 centimeter below, +1, so it's stage 3. Total vaginal length outside, it's stage 4. Again, I will repeat. What is the stages of prolapse? Stage 0, every point in place, or point C or point D descends only for 2 centimeters from the total vaginal length to total vaginal length -2. Means from 8 centimeters by -8 to -6. This point came from here to here. This is stage 0. If more than this, it will be stage 1. What is the criteria of stage 1? Higher than the hymen by more than 1 centimeter. So it will be higher than -1. What is the criteria of stage 2? Take stage 2 as a landmark. Why? It is very important stage. 1 centimeter higher than the hymen or 1 centimeter lower than the hymen. This is stage 2. And until here, you can do pelvic floor muscle exercise. Why? Because it will be effective. If the prolapse go more than this, no pelvic floor will control the prolapse. You will do exercise and protrude it outside, because the pelvic floor is higher than the prolapse. Does it make sense? So pelvic floor muscle exercise is relevant only for stage 1 and 2, not for 3. It will be below the level of pelvic floor muscle exercise. So make a landmark by stage 2, because it is -1 above the hymen and +1 below the hymen. 1 centimeter above or 1 centimeter below in this level is stage 2. Why stage 2? It is important because until this point of prolapse, you can do pelvic floor muscle exercise. Otherwise, you cannot. More than 1 centimeter below the hymen, it will be stage 3. Total vaginal length outside, it will be stage 4. Again, everything in place, point A in place, point A anteriorly or posteriorly Point B anterior or posterior, all are higher, -3, higher than -3, and C or D descend by 2 centimeters from the total vaginal length -2, so from -8 to -6. This meant by total vaginal length -2. So everything in place, or point C or D descends for 2 centimeters from the total vaginal length. Okay? So until now, nothing is there, my dear. I will do nothing, no treatment. If this criteria is not met, means the leading point is higher than 1 centimeter above the level of the hymen. This is stage 2. Take stage 2 as a landmark, 1 centimeter below and 1 centimeter above. The leading edge is higher than the hymen by 1 centimeter or equal, means it is here. 1 centimeter is in stage 2. To be in stage 1, it should be higher than 1 centimeter. So if the leading point or the prolapse came around the hymen by 1 centimeter, it is very important to remember stage 2. More than 1 centimeter until +6 means total vaginal length -2 centimeter by plus, because it is below the hymen, so stage 3. If it is +8 means total vaginal length all outside, it will be stage 4. I think I make it very easy. Again, this is the stages. Stage 0, everything in place. Stage 1, descent until 1 centimeter higher than the level of the hymen. If it is 1 centimeter, it will be involved in stage 2. Stage 2, 1 centimeter above or below. Stage 3, more than 1. So +2, +3, +4 until +6, this will be stage 3. +6, +7, +8, this will be complete procedentia, all stage 4. Again, the exam question can come by figure or by shape. It's nothing. It's just a play. Just you will know what you will do. So if it brings this or this, I know what I will do. This point should be here. This is the vagina. This is the jam jar. This point should be here at -3. Why it is prolapsed? So there is a prolapse. This is the symphysis pubis. And this point should be here. It is prolapsed. So this is anterior wall prolapse. I will do anterior repair. The other points are still some in place, not completely prolapsed. So this patient will take a benefit from anterior repair. The other criteria here is the symphysis pubis and the anterior wall is in place, but the posterior wall is prolapsed. This point is +3 and this point is +6. So mainly posterior wall prolapse. I will do what? I will do posterior wall repair for this patient. So the exam question can come as a figure or a number and nothing. It's all the same. If he put the point, this point, I know it should be at -3. Why it became +3? Anterior wall prolapse. Point B anterior, it should be at -4, 5, or -6. Why it's here? It's anterior wall prolapse. Cervix, it's descent from -7 or -8 to -2. So it is grade 1 vault prolapse. Why? Because it is higher than -1. If it is -1, it will be grade 2 vault prolapse. Genital hiatus dilated. Why? There is a bulge coming from the vagina, my dear. The perineal body is deficient. Why? There is short perineum. The total vaginal length is fixed. 6 centimeters because he removed the cervix. Point B, point A posteriorly, mostly in place, -3. So it is not prolapsed. Point B, it is prolapsed below her level. It should be higher than -3. And point D is not here because he removed the uterus. Douglas pouch is not there. So this is anterior wall prolapse treated by anterior repair. Very simple, easy marks in the exam. POPQ is not a magic. It's easy, but we don't understand. Again, the same number. Point A anteriorly
you are
in
the one
place.
who make it easy. Thank you so much.
Thank you much. Thank you very much, my friend. Thank you very much. Let's proceed. I will give you magic today, like the big show. So if the question came like this or like this, I will play in the exam. I will be confident about what I am choosing. I will not hesitate. Nothing. What do you think? This is a joke for me. Uterus is there or uterus prolapsed. I know where the point should be. This point should be here, -3, -4, -6. This point should be here at -7. This point should be here. So this is the normal jam jar. -3, higher than -3, -8. Perineal or genital hiatus 2 centimeter, perineal body 3 centimeter, total vaginal length 10 centimeter, the posterior wall all in place. So I will be happy by this POPQ. Everything in place. This woman have grade 4 prolapse. Why? Everything is prolapsed to the maximum point of prolapse. Point A anteriorly +3, point B anterior +8. Cervix is completely at +8. Genital hiatus is large because everything is outside. Perineal body is decision. Total vaginal length is the same, but outside from here to here. The posterior wall, again, outside. Point B posteriorly at +8, complete percentage. So if the exam question came by point or by number, I will be happy. It will make no difference for me. It's a joke. So POPQ terminated. Go for another thing. Urodynamic. It's a joke, but we make it difficult. I suffered for 2 or 3 years with urodynamic. By one day, I decided to study urodynamic alone. I bring all the books, everything for urodynamic to understand it. Then I decided to know what is urodynamic. It's nothing, my dear. It's a joke. It's a play. I will put the patient on a commode, a chair to pee, and I will collect this pee to have a figures or a number or a shape. So a simple cystometry, I will ask the patient, please sit on this commode and make a pee, and I will collect it in a special container, attach it to a graph to make a euro graph. This is the uroflowmetry. It should be a bell shape, and this is the Qmax, about 15 or 25 maximum. So this is the uroflowmetry, simple urodynamic. What is the cystometry? I will put two catheter, one in the vagina and one in the bladder and one in the vagina or rectum. And I will take a graphs from each catheter here. I will take a graph. The bladder catheter will give me the vesical pressure, and the vaginal or the rectal catheter will give me the abdominal pressure. And I will subtract both of them to get the detrosal pressure. So the story, I will bring a patient, tell her to sit in the commode and give me your pee, please. And I will collect this with a computer to have a chart for the uroflowmetry. After she pass urine, I will put a catheter in her bladder, and I put a sterile water in it, and I will figure, or I will do a graph for her. When she will feel the points, or when she feels the desire to be, and where to feel the maximum desire to be, and I will record the first dose or the first desire. It should be at 20 cc, but she feels at 100, so reduced her bladder sensation, or the patient have detrosal overaction. The maximum bladder capacity should be 400 to 600. If she feels irregular, means she have reduced bladder capacity. So this is the urodynamic during filling or during voiding. Okay, so what I will do with this chart, I will play another game with this chart. What is the game? Go for the next slide. This is how to calculate the chart. A catheter in the bladder to get the vesical pressure. A catheter in the rectum or the vagina to get the abdominal pressure. The pressure here is higher than here. I will subtract both of them to get the detrosal pressure. Nothing. What's the problem? 3 lines on a chart. Then I will go for the interpretation. What is the interpretation? This is a very easy demonstration who will give you all the criteria in one graph. This is the normal response. I will put the 3 catheter and I will tell the patient to cough. If she have a spike here and a spike here and no leak, so the patient, the vaginal catheter, and this is the bladder catheter, and this is the detrosal pressure. The vaginal catheter giving me the abdominal pressure. The patient coughs means this is a spike here. The detrosal pressure will not be changed, but the vesical pressure will be transmitted from the abdominal to the vesical. It will be a cough, no leak, no change in the detrosal pressure, and no leak here. So this is a normal response. I will interpret only the charts from the catheters. Okay. Again, I will tell the woman to cough. If she leaks, it is stress urinary incontinence, and confirmed by urodynamics. This means a urodynamic stress incontinence. And usually, I don't want to do a urodynamic for stress incontinence. It is not indicated. It is a clinical situation. So if you have signs and symptoms of stress urinary incontinence, you don't need to do urodynamic. It is a clinical. Tell the patient cough, she will leak. Stress urinary incontinence. If you did urodynamic, it will be urodynamic stress incontinence. Easy marks. Okay. I told the patient to void. She increased the detrosal pressure. She passed urine and she have the pill shape. Normal voiding. So this is the filling phase and this is the voiding phase. The only problem, if the patient have detrosal overactivity, there is no abdominal pressure increase, no cough or sneezing or laughing. The detrosal muscle is contracting by her own, raising the vesical pressure, and there is a leak. Detrosal overactivity. If you find detrosal change, means detrosal overactivity. With or without a leak means wet or dry overactivity. Another play in the exam. Any problem in the urodynamic?
This chart, can you repeat, please?
Detrosal overactivity.
Please repeat.
Okay. You will put the 3 catheter in the woman, and you will get 3 charts. One from the vesicle, one the vesical catheter, one from the abdominal pressure. And you will subtract this from this because the vesical pressure will be higher. That pressure of the detrosal and the pressure of the abdomen, the higher pressure here is the vesical pressure. I will subtract the vesical pressure minus the abdominal pressure, I will get the detrosal pressure. If I told the woman to cough and these 2 pressure will be increased. Why? Intra-abdominal pressure from the cough, intravesical pressure transmitted from the cough, but the detrosal muscle is stable. So it is a stress urinary incontinence. I have a urodynamic, it will be a urodynamic stress incontinence. The patient does not cough, but there is irritability and contraction in the detrosal muscle. It will be transmitted from here to here. So I have a change in the detrosal muscle and a change in the vesical pressure and no change in the abdominal pressure. So simply, if you have contraction in the detrosal muscle, it is detrosal overactivity because the abdominal pressure does not change. The detrosal muscle contracts, raising the vesical pressure, causing for leak. This is detrosal overactivity. Very simple. If you notice detrosal pressure high or change it, means this is detrosal overactivity. In normal response, no change in the detrosal muscle. In stress urinary incontinence, it is transmitted from cough or laugh or jumping, no change in the detrosal muscle. Simply, if you find detrosal action, means detrosal overactivity transmitted to the bladder, giving a leak. So detrosal overactivity with a leak, wet, without a leak, dry. Very simple. Does it make sense? another game in the exam.
Can please Dr. Hani explain a tonic bladder and sensory bladder? We have problem also with this.
Okay. The problem here, you are doing a filling phase and voiding phase. In the filling phase, the patient is doing B without feeling her bladder, atonic. In the filling phase, the patient have no sensation and she have leak or she have passed urine without feeling or reduced feeling, atonic bladder. Very easy. If the patient have reduced sensation or if the patient have irritable uterine or irritable bowel contraction during filling phase, this will be aditrosyl overactivity. If the patient have reduced filling or reduced first sensation without any detrosal muscle, it will be sensory bladder. So think about the filling phase. If the woman have contraction, detrosal overactivity, so detrosal overactivity. The woman have no detrosal pressure, only reduced, it will be a sensory. The woman have passed urine without any sensation, it's atonic. Very simple. It will give you the clue. The pressure of the detrosal muscle changed, so detrosal overactivity. Don't changing, and the patient have early sensation, so sensory. The patient have no sensation, so atonic. Very simple. Does I make it clear? I will make it magic for you because we are making things tough for us. It's easy, but just to understand.
Excuse me, sir. What about outflow tract obstruction? Outlet obstruction graph.
There is another thing to check the urethral. This will go for, I usually give this session in more than 6 hours, my dear, but I am giving you the tricks. There is another thing to measure the urethral blood pressure, to differentiate between the urethral outlet obstruction. I will make a free. You have something here.
The previous graph.
I will give you all the PDF, my dear. There is to measure the urethral pressure, to differentiate between outlet obstruction or bladder hypotonia. Simply, if you find all the pressure is low, means this is atonic bladder. All the pressure is low, here low, and the woman have no B or the P is prolonged, so atonic. You will find the bladder pressure is low, the vesical pressure is low, the detrosal pressure is low, have no sensation. Obstruction here, you will find the high pressure here, high pressure here. Simply. Does it make sense? This is how to differentiate between.
And again, Dr.
Yeah,
how to
we will
differentiate
find
between
it?
Hypotonic bladder and bladder outlet obstruction. In hypotonic bladder, you will find all the pressure low. The bladder is not contracting. There is no urine coming outside. The bell shape will be like this. So no urine is passing outside because the bladder is hypotonic. You will find the bladder pressure is low. The urethral pressure is low. A hypotonic bladder. If it is high, means obstruction. High pressure, high urethral pressure, obstruction. Very simple. Clear? So let's go to another magic. Now we finished the CIN, we finished the urodynamic, we finished the POP-Q. All this was a hazy point in the syllabus. The postmenopausal ovarian cyst is a very important topic and always coming in the exam. Why? Because the chance of having malignancy. A postmenopausal cyst more than 1 centimeter needs a screening. A woman more than 51, so postmenopause, have 1 centimeter cyst, need a screening. What will be the screening? To calculate the risk of malignancy index. The MRCOG, depending on the risk of malignancy index in triaging the patient, not the iota. Does it make sense? So this is another exam question. not the aorta. I know a lot of mentors said the aorta can be higher. No, the RCOG taking the RMI as a triaging system. Why they put this in the chart? So the RCOG calculating the risk of malignancy index to transmit. Not the aorta, my dear. For postmenopausal woman, the risk of malignancy index is the one responsible for triaging patient is a low risk or high risk. So in a postmenopausal woman having cyst more than 1 centimeter, I will go for the RMI. I will do transvaginal ultrasound scan. I will calculate the risk of malignancy index, the menopausal state, the scan finding, and the cancer antigen 125. If the risk of malignancy index less than 200, I will go for the criteria of the cyst. Simple cyst, asymptomatic, simple cyst, less than 5 centimeter, unilateral, I will go for the conservative treatment. Follow up every 4 to 6 months. If persistent for 1 year, I will individualize the woman. If resolve, I will discharge. If increased, I will go for bilateral salpingio-oophorectomy. There is no unilateral in a postmenopausal woman. The treatment is bilateral salpingio-oophorectomy. Why? If any criteria from this is changed, means more than 1 centimeter, symptomatic, non-simple, bilateral, I will go for bilateral salpingio-oophorectomy. If the cyst is 1 centimeter painful, I will go for bilateral salpingio-oophorectomy. If the cyst is bilateral, I will go solid cyst more than 1 centimeter, symptomatic. Any single criteria of this is changed, I will go for bilateral salpingio. What's a bilateral salpingio-oophorectomy? If it is the same, I will continue conservative 4 to 6 months. If it is the same, after 1 year, persistent for 1 year, I will speak with the woman, discharge or remove. Very easy. If the risk of malignancy index more than 200, I will do a CT. Why? For staging, before referring the patient to a multidisciplinary team. So CT, then refer the patient. And this is an exam question. A patient postmenopausal with 1 centimeter cyst have a suspicious criteria, and the cancer antigen 125 is more than 50, so it will be risk of malignancy index more than 200. I will do what? A CT for staging. CT for staging, no MRI. MRI for invasion, for assessing. Assessing for what? Invasion of endometrial thickness, invasion for accreta if the ultrasound is inconclusive. All these are exam tricks. So CT for staging of a cancer, MRI for invasion. Invasion of what? Invasion of endometrial hyperplasia. Less than 50% of the endometrium or more than 50. It will differ in the treatment. Invasion of what? Invasion of placenta previa. Don't disturb me, please. Leave me until the finish and ask your question, please. I will mute all. Let's continue the magic, because these are coming. I give you more than 50% of the exam question in this slides. So they like the postmenopausal woman, the triaging system by the risk of malignancy index. Less than 200, more than 200, more than 200 CT for staging. Then if you find the patient is high likelihood for malignancy, go for staging laparotomy, full staging procedure by a gynecologist. If you find the patient a cancer or low risk of ovarian malignancy, you will go for a pelvic clearance, total abdominal hysterectomy, bilateral salpingio-oophorectomy, omentectomy, peritoneal cytology by a suitable trained gynecologist. So according to the CT, I will refer the patient for a multidisciplinary team after doing a CT to assess the metastasis. Okay?
Sir, please, what is the difference between pelvic clearance and the staging? I think it is the same.
No, my dear. Staging, you are having a look before doing a decision. Staging laparotomy. you will do a full staging laparotomy. You will open the patient from the symphysis pubis to the sternum to assess the cancer before giving a treatment. This is a multidisciplinary team decision. Laparotomy for full staging procedure by a gynae oncologist. Does it make difference? If a low risk for malignancy, you will go for a pelvic clearance from the start, not a staging laparotomy, and can be done by a gynecologist, not by a trained gynae or a gynae oncology. Okay?
Okay, sir. Thank you.
Welcome. Endometrial hyperplasia. The gold standard.
So just one question. What if they ask for triaging for the premenopausal cyst?
A perimenopausal, you
iota?
consider iota, but according to the criteria. In a postmenopausal, the risk of malignancy. Okay? Okay. Let's go for the endometrial hyperplasia. A transvaginal ultrasound is the gold standard screening measure. Why? To check the endometrial thickness. The endometrial thickness is 4, 7, and 11. What is the 4, 7, and 11? 4 for postmenopausal, 7 for perimenopausal, 11 for a woman on tamoxifen. These are the cut value to take an action. 4 for postmenopausal woman. Endometrial thickness more than 4, you will go for a sample. 7 in a PCO or a perimenopausal woman, endometrial thickness more than 7 millimeter, you will go for a sample. 11, you will go for a sample. It can be appliance sample for screening, like the endometrial or Bible sample. It will be appliance sample, not diagnostic. If you find an abnormality, you will go for hysteroscopic sample to have a clear view about the endometrium. So what is endometrial hyperplasia? Endometrial hyperplasia can be typical or atypical. The patient having endometrial hyperplasia without atypia or with atypia. If the woman have endometrial hyperplasia without atypia, give her Mirena as a first line. Oral progesterone is the second line. Why? Because that chances of regression is much more higher than with Mirena than the progesterone. Why? Because the level here will differ and the follow-up will differ. If the woman treated by Mirena, you will give her 2 consecutive negative sample. If negative, discharge. But if the woman treated by progesterone, and you will follow up here annually after that, because the chances of regression is much more higher with Mirena than the progesterone. Again, if the woman have endometrial hyperplasia without atypia, she will have 2 options. The first one will be Mirena as a first line. The second line will be oral progesterone for 6 months. Then the follow-up will be endometrial sampling every 6 months. Okay? If a woman have atypical hyperplasia, the definitive treatment will be total abdominal hysterectomy with bilateral salpingioophthalmectomy. This is the definitive treatment. If the woman is young and does not complete her family, you can consider a fertility conservative surgery or conservative maneuver for her. You will put for her what? You will put for her a Mirena or treat by progesterone, but you will follow up every 3 months. So the follow-up after treatment will differ from without atypia or with atypia. Without atypia every 6 months, with atypia every 3 months. If the woman wishes her fertility, you will follow up here for 1 negative sample. If she have 1 negative sample, you will refer her for the fertility specialist to have a baby, and after that to complete her family and remove the uterus. Total abdominal hysterectomy with bilateral salpingioophthalmectomy. This is an exam question. So after the treatment and the follow-up will be a regression, a progression, or a persistence, or a progression. A regression, the Mirena can be kept for 5 years for contraception, but 4 years for protection of endometrial hyperplasia. This information from TOC. For contraception for 5 years, or endometrial hyperplasia protection for 4 years. Oral progesterone should be for continuous for 6 months. Total hysterectomy with bilateral salpingo-oophorectomy if the woman have any abnormal bleeding. Okay, the follow-up will be 6 monthly for this woman for 2 negative sample if it is treated by Mirena. If the woman is treated by Mirena and the BMI is less than 35, because the BMI is a risky for endometrial hyperplasia. So this patient will be followed for 2 successive negative samples, then discharge. If the woman is treated by progesterone or the BMI is more than 35 or more, you will go for annual endometrial biopsy and review. Does it make sense? If the woman is treated by progesterone or BMI is more than 35 or more, you will go for 2 consecutive negative sample, then annual thereafter. This is an exam question. If she have atypical hyperplasia, then you will see it every 3 months until 1 negative only. If 1 negative only and she have atypical hyperplasia, refer her to fertility specialist and have a baby, and once she completes her family, remove or go for the definitive treatment. If the woman have regression, if the woman have persistence for 1 year,
Excuse me, sir. Could you please repeat the follow-up once, please?
I will repeat it again after I finish the chart. Okay.
Yes, sir.
Okay. So if the woman have persistent endometrial hyperplasia, even you didn't treat her, you go for conservative only, and the patient have endometrial hyperplasia without atypia, you can start the treatment after 1 year. Okay. So if the woman choose to be conservative, give her Mirena or progesterone tablet after 1 year. If the woman have persistent after the treatment for 1 year, go for total abdominal hysterectomy and bilateral salpingo-oophorectomy. Atypical hyperplasia, persistence, go for total abdominal hysterectomy and bilateral salpingo-oophorectomy. Any progression, go for total abdominal hysterectomy with bilateral salpingo-oophorectomy. So what is the patient's situation and what's her fertility wishes? Always think about this. If the woman have endometrial hyperplasia without atypia, give her a Mirena and follow up for 2 6 monthly negative successive or 2 consecutive negative endometrial hyperplasia or endometrial biopsy. If post negative for 1 year, discharge here. If she have treated by oral progesterone or the BMI 35 or more, don't discharge here. This is an exam trick. Follow up here for 1 year, 2 consecutive negatives, then annual review. Okay? Why? Because the risk, the patient have a risk. The BMI is risky factor. If you know the risk factor for endometrial hyperplasia is obesity, HRT, and PCO, and tamoxifen. So if the woman have BMI more than 35 or treated by progesterone because the less compliance of the treatment or the less effectiveness of the treatment, I will follow up here annually until removal or until regression. Even if there is regression, I will continue follow up of the patient if she have a risk factor. What is the risk factor? BMI 35 or more or treated by oral progesterone. Okay? If atypical hyperplasia, the follow-up will be every 3 months. If the woman wishes to have her uterus, she's a young girl and she didn't complete her family, so I will give her a Mirena and follow up every 3 months. If the woman have any atypical hyperplasia, the definitive treatment is total abdominal hysterectomy with total hysterectomy with bilateral salpingo-oophorectomy. What is the route? Better to go always for laparoscopy. Why? Laparoscopy is cost effective, less bleeding, less time of recovery, early ambulation, and less cost effective for the NHS. So any maneuver, choose laparoscopy because a higher benefit of laparoscopy than laparotomy. Does it make sense? Any question about the endometrial hyperplasia? I still have one topic only to discuss. So, a trick.
if we have a patient with the atypical hyperplasia and we give her Mirena, how much samples, and she wants fertility also, still we will take one sample or two samples before we let her become pregnant?
Answer in talk, my dear. It will be one sample only, and if negative, refer her for fertility specialist until she have a baby, then remove the uterus and the ovaries. Okay. There is another
and can such a patient use progesterone, or only she will have Mirena?
Use progesterone, but the problem, the progesterone is less effective than Mirena.
Okay.
Sir, till when I will follow after negative endometrial sample for women more than 35? Till when?
One negative sample only is enough to refer her for fertility specialist. Okay.
No, sir. I don't mean fertility. I don't mean. I mean the endometrial hyperplasia without atypia, and for obese women or receiving oral progesterone. Till when I will do annually? How many times? Or just after 1 year, after 2 consecutive negative?
If 2 consecutive negatives 6 months apart with no risk, discharge the patient. If it is persistent and the patient having a high risk, you will continue for 10 years. Annual, not for 10 years, sorry, it will be annual review until the patient decide will go for regression or will go for removal. So you will continue annual removal forever. No time. She still have a risk because the patient BMI or treated by progesterone, it's annual follow-up. Okay, until she do a hysterectomy or she will continue on annual follow-up. No time for stopping. Okay. There is another trick written in the guideline and nobody taking care about it. This trick is saying a woman even with atypical hyperplasia will have the difficult treatment, the definitive treatment. What is the definitive treatment? Will be total hysterectomy with bilateral salpingiorectomy. Woman with atypical hyperplasia with atypia or endometrial hyperplasia with atypia should undergo a total hysterectomy because the risk of underlying malignancy. Okay. A laparoscopic approach is always better. A quick recovery, less hospital stay, less cost-economics. So always think about laparoscopy than laparotomy. There is no benefit from the intraoperative frozen section. And the postmenopausal woman with atypical hyperplasia should be offered bilateral salpingiorectomy together with total abdominal hysterectomy. A postmenopausal woman don't leave the ovary, but take this surprise. A perimenopausal woman, even with atypia, you will remove the uterus and the tubes only. You will not remove the ovary because she's still young. The ovary will protect her from, as a HRT rule, the ovary will protect her from osteoporosis, from menopausal symptoms, and from having a fracture. Osteoporosis, menopausal symptoms, and cardiovascular risk before, or cardiovascular stroke before the age of 60. So in a perimenopausal woman, don't remove the ovary. The decision to remove the ovary should be individualized. However, bilateral salpingectomy should be done. So you remove the uterus and the tubes. Even in hyperplasia with atypia, in a perimenopausal woman, don't remove the ovary. Why? The new trend of the RCOG to keep the ovary, to protect the patient from the menopausal symptoms and protect her from the osteoporosis and protect her from the cardiovascular risk before the age of 60. So it is written in the guideline, but nobody read probably. Ovarian
I'm sorry, sir. If we found after removal of the uterus there is underlying invasive carcinoma, I go again and remove the ovaries in the premenopausal females?
In a perimenopausal woman with, I am not saying cancer now, my dear. Cancer is another thing.
Yes, sir. I mean, after I diagnose it as atypical hyperplasia, but after pathology, histopathology, it is an invasive carcinoma. I go and for another session and remove the ovaries?
It's not for you, my dear. You will go for multidisciplinary team. Respect your level. Okay? Know your limit. Your limit is here. Your limit is ST5. If you proceed ST5, it should be a multidisciplinary team level. Endometrial hyperplasia with atypia for a perimenopausal woman, you can consider or you can remove the uterus and the tubes only without ovary. Why? Because the risk of menopause and HRT and the risk of osteoporosis and cardiovascular stress. But you will remove the tube because the tubes are always giving the risk of malignancy. Okay?
Okay, sir.
So let's continue. Just we read difference. To have the knowledge, we need to read difference. So let's go on, and I will give you all the question by the end. The last topic today, which I want to give you about it, after that, I will open the discussion for any part of the syllabus. Ovarian hyperstimulation syndrome is very important, and if you find this picture in a patient, please remember to report the patient for the IVF center and the HIFIA. What is the IVF center? The IVF center who did the complication. The HIFIA is the Human Embryo and Fertilization Association or authority. Why? To know that there is a complication and the follow-up. So if you find ovarian hyperstimulation syndrome, you will report for the center who did the IVF, and you will report to the HIFIA, the Human Embryo and Fertilization Association, because this is a complication of fertility problem. Okay? So the first thing is to know what is you will do. You will manage the patient and you will report the patient for the IVF and for the fertility center and for the HIFIA. What is the risk? Mild or severe? Mild about 1/3, about 33%. Moderate to severe, it's about 3 to 8%, as I remember from the guideline, all the numbers written in the guideline. So ovarian hyperstimulation syndrome symptoms, history and symptoms. History, the onset, medication for trigger of induction, number of follicle collected, number of eggs, embryo, where is the embryo replaced or no, because if the woman have embryo replaced and ovarian hyperstimulation, she will be at a high risk during the first trimester and the regression will be difficult. Because usually a non-pregnant woman with ovarian hyperstimulation regressed by the next period. But if the patient got pregnant, she will be difficult in regression and she will be monitored for the first trimester and she will be at a higher risk. So if a woman develops ovarian hyperstimulation syndrome, don't put the embryo back, keep the embryo frozen and think about delaying replacement of the embryo, and it will not affect the fertility chances of the woman. Okay? Symptoms: abdominal bloating, discomfort, analgesia, but avoid the non-steroidal anti-inflammatory. Remember, non-steroidal anti-inflammatory is not given in epileptic woman, is not given in a woman with sickle cell until between 12 to 28 weeks. Non-steroidal woman is not, non-steroidal anti-inflammatory is not given for a woman with infection. It affects the polymorphic action. So the polymorphic mode of action or phagocytosis. So non-steroidal anti-inflammatory is not for a woman with ovarian hyperstimulation syndrome. Non-steroidal anti-inflammatory is not for a woman with infection. Non-steroidal anti-inflammatory is not for a woman with sickle cell disease unless between 12 and 28 weeks of gestation, contraindicated before and after. Non-steroidal anti-inflammatory is not a good choice in this situation. So in a woman with symptoms like this, suggesting ovarian hyperstimulation syndrome, abdominal bloating, abdominal discomfort, need for analgesia, nausea and vomiting, breathlessness, reduced urine output, leg swelling, vulvar swelling, associated comorbidity as venous thromboembolism. If a woman has ovarian hyperstimulation syndrome and came with acute pain, so it is a torsion. Came with sense of fullness, bloating, tightening of clothes, ovarian hyperstimulation syndrome. Exam close, exam question. Ovarian hyperstimulation syndrome came in the second day with acute pain, torsion. This is not an ovarian hyperstimulation syndrome. Came with sense of fullness, bloating, and having tight clothes. This is ovarian hyperstimulation syndrome. Clinical sense. Exam tricks. Examination, general assess hydration, blood pressure, pulse temperature, abdominal examination for ascites, palpable mass, and measure the girths. Respiratory, if there is any respiratory affection, pleural effusion, pneumonia, and edema. Investigation, full blood count, hematocrit is very important in classifying. If it is 45, 45, or 55, you will be in a different grade. C-reactive protein, edema, serum osmolality, liver function test, coagulation profile for thrombosis. The patient is high risk for thrombosis. Mild and moderate can be treated in outpatient. Severe patient, symptomatic, should be admitted. Remember the VTE prophylaxis. Coagulation profile, because high risk of thrombosis, beta-HCG, because it will reduce the recovery of the patient if the patient got pregnant, so it will be a high risk of regression. Ultrasound to estimate the ovarian size, it will differ in the grading of the disease. Consider ovarian Doppler if you suspect a torsion. Other tests may be needed: arterial blood gases, D-dimer, ECG, chest X-ray, computed to CTPA, or PQ scan if you suspected pulmonary embolism. Categorization is very important. Mild ovarian hyperstimulation syndrome, mild symptoms, mild abdominal pain, ovarian size less than 8, moderate if more than 8 to 12. Patient have symptoms, ultrasound evidence of ascites, so it will be moderate ovarian hyperstimulation syndrome. Mild and moderate can be treated outside without admission. Severe cases, even a patient can come for follow-up. Some cases can be treated, as I remember, outpatient, but if the patient is deteriorating or cannot come for follow-up, it should be admitted. Critical should be admitted. So the difference here, in severe cases or critical cases, should be better to be admitted, or should be admitted if there is clinical ascites, oliguria, hematocrit more than 45, a very important landmark. So severe ovarian hyperstimulation, look for hematocrit. Critical, look for hematocrit. Hyponatremia, hypoosmolality, hyperkalemia, hypoproteinemia, and ovarian size more than 12. So ovarian size is important to give you a degree. Hematocrit is very important to give you a degree. Okay? I finished my target. Would you take a break now, or go for the mock exam and make the discussion at the end?
Take a break, sir, please.
Mock exam, mock exam.
I will take a break, only 10 minutes, then we'll go for the exam and open the discussion. 10 minutes only break.
This conference will now be recorded.
Let's do a mock exam. It will be about 40 questions. I know that your time now is very precious, so we will practice only some questions on the topics today, and then after that I will answer. I will be happy to answer all your doubts. The first one is Dr. AA. It's your turn. If you want to share, if you don't want, please stay muted. Dr. AA, would you like to share? Okay. This is the option. Usually in EMQ, I am not reading the option. I start by the head of the question, then I will go for the question. This is the question. Please read the question, Dr. AA.
Yeah, a 27-year-old woman had her second smear that came back as borderline. High-risk HPV test is positive.
So what you will do in this situation?
colposcopy in 6 weeks' time.
Excellent. You will refer the patient for colposcopy within 6 weeks.
Yes.
Thank you, Dr. Ahmed or Dr. what?
Arafat.
Dr. Arafat. Thank you, Dr. Arafat. Dr. Abir Deep, your turn.
Assalamu alaikum. 37 years old, has low-grade dyskaryosis with high-risk human papilloma virus negative. Routine record.
Excellent. Low-grade dyskaryosis with human papilloma virus negative. I will go for routine record. Thank you, Dr. Abir. Dr. Aisha Yassin, you are the next one. Question number 3.
Okay.
Dr. Aisha.
Yes, ma'am. Yes, I with you, Dr. Hani.
Question and answer, please.
26 years old woman. 1 minute, I didn't saw. 26 years old woman had first smear which she was moderate dyskaryosis for
If you
colposcopy.
find moderate dyskaryosis in the sample, what you will do?
Moderate and severe for colposcopy.
Colposcopy within?
Yes.
Colposcopy within 2 weeks, okay?
Yes, within 2 weeks.
Okay. So if he came like this, the question came like this: a 26 years old woman has her first smear with moderate dyskaryosis. If he said that human papilloma virus positive, human papilloma high risk human papilloma virus positive, now he follow the new screening. So I will go for checking the cytology. Does it make sense? Human papilloma virus positive.
Yes.
If he said, now he will change to the new screen. If the question came like this. Thank you, Dr. Abir. Who's next? Dr. Aisha, Dr. Ahmed Safwa.
But in this one, I will not do HPV first.
If he said in the question, the patient have human papilloma virus positive, so now he changed. He follows a new screening, not the cytology. Does it make sense, Dr. Ahmed?
No, sir. So, I mean, if he wants a moderate dyskaryosis, the next step after dyskaryosis will be HPV testing. If positive, I will take her for colposcopy.
No, my dear. This question is still according to the previous screening. If he said 26 years old woman in her first smear have human papilloma virus positive, now he follows the new screening. You will go second step for the cytology screening. Okay?
So you mean moderate dyskaryosis is high grade?
Yes, this is according to the old screening. Moderate dyskaryosis is intermediate, so you will go for colposcopy within 2 weeks. High grade dyskaryosis or moderate dyskaryosis, you will go for colposcopy. This is according to the first one, 2016 chart. This is your question, Dr. Ahmed.
Hello. 46 years old, a woman has 3 inadequate smear repeated 3 months apart. Routine recall?
No, my dear. This has 3 inadequate smear repeated 3 months apart. So 3 inadequate smear will be referred to colposcopy within 6 weeks. This is the first rule. Okay?
Okay.
If you have inadequate smear, you will repeat after 3 months. If you repeated it 3 times, means the patient should be referred to colposcopy. This is the first indication to refer to colposcopy. Okay? Who's next after Dr. Ahmed? Thank you, Dr. Ahmed. Dr. Ala.
Sorry, doctor, I cannot share with you because I have problem in my screen, in my connection.
Thank you
The
very
screen
much.
will not appear for me.
No problem.
It appear after a while.
Okay, no problem.
Thanks. Thanks.
Dr. Amal?
A 30-year-old woman had leads for CIN3. Test of cure after 6 months. That means cervical.
Did she say criteria to repeat leads?
No. Test of
So the
cure.
woman is less than 50 and a treatment for CIN3, it is not CGIN and no invasion. So I will do what?
Test of cure. Only test of cure.
Yes. I will refer the patient to the GP. I will do test of cure after 6 months.
6 months.
Question number 6. The next one in chat after Dr. Amal. Another Dr. Amal. If you would like to share. Dr. Amira Gilani. Dr. Amira, if you will share, or I will pass. دكتورة المسلمي محمد. دكتور محمد المسلمي. دكتور أنيسة. دكتور أنيسة MS. If I keep calling and nobody answering, so what's the benefit?
Yes, sir.
Okay. Go on, please. Question number 6.
A 35-year-old woman had cone biopsy for CGIN 6 months ago. Test of cure is negative at present.
So if you find CGIN, what you will do?
Biopsy.
The patient has CGIN and a woman has cone biopsy for CGIN 6 months
so test of
ago.
cure 6
Test
months.
of cure now negative.
Now
She did the treatment and she did the test of cure at 6 months. What you will do?
Repeat the test after 12 months. Repeat at 12 months again test of cure.
Yes, the second test of cure after 12 months. It will be individualized as a colposcopy or test of cure according to the local practice. Question number 7. Dr. Anu. Dr. Anu. Dr. Anu, if you are free. Dr. Arti. Dr. Arti. Dr. Asma Sheikh. Dr. Asma Sheikh.
Yes, Dr. Hani. A 55 years old woman had leads for CIN3 and the deeper margin are not clear for CIN3. So I will repeat leads again.
So this patient have what? Have breached the limits, 55 years old, and have leads for CIN. And the margin is unclear, still CIN in the margin. So in this patient, I will repeat leads. Okay?
Okay.
So I will do leads for this patient. Thank you, Dr. Asma. Next, Dr. Ayman. Dr. Ayman.
Yes, with you.
Question number 8.
45-year-old had excision and treatment of microinvasive cancer, FIGO stage 1A1. The excision margin shows CIN. So I will do leads.
Excellent.
Treatment.
Why?
Because stage 1A1.
No,
Still
because there
there
is
is
invasion.
place.
Microinvasion.
Yes. Microinvasion. Yes.
Follow the rule. If the woman more than 50, there is invasion or CGIN. I will do leads. So the answer,
yes.
I will do leads again.
Yes.
Okay. So the next one after Dr. Ayman, Dr. Azra. Dr. Azra Barbin. Dr. Azra Parvin, if you want to share, this is the next questions. Dr. Basima. Dr. Basima. Dr. Bushra. Question number 9. Dr. Bushra Saad. DP.
A 28-year-old woman attends her GP surgery for a routine cervical smear. The examination is difficult and inadequate results is returned. Then we repeat at 3 months. Repeat the cytology
Inadequate.
3 months. Yeah,
Yes, inadequate.
Repeat in 3
Excellent.
months. Thank you.
Thank you very much. Dr. DB. One doctor, yes.
A 35-year-old woman attends her GP surgery for a cervical smear, having never had a smear in, in the past. A result of high-grade dyskaryosis is returned. High-grade, 6 months?
If you find high-grade dyskaryosis, what you do?
Colposcopy, loop excision, right?
You will do colposcopy. Within how many weeks?
Within 2 weeks.
So colposcopy within 2 weeks. Thank you. Next for Dr. Darun. If you would like to share, question number 11. Dr. DD. Dr. Dina.
Dr. Hani, a 31-year-old woman attends the GP surgery for cervical smear. This is reported as a low-grade dyskaryosis and HPV test is organized. Unfortunately, the HPV test is inadequate. This is colposcopy. Refer to colposcopy.
Yes, low-grade dyskaryosis was inadequate. I will refer for colposcopy. Thank you, Dr. Dina.
Thank you.
Dr. Devia. Dr. Devia. Dr. Devia. Dr. Desmu. DSDM Demsu. Dr. Demsu, if you'd like to share.
Dr. Hani, I wanted to ask a question.
Yes, Dr. Wafa.
Yes. If here the smear low-grade dyskaryosis and the HPV is inadequate, why we didn't repeat HPV after 3 months?
This is according to the old screening. It is low-grade dyskaryosis. Low-grade dyskaryosis refers a patient for colposcopy. Okay.
This question according to the okay. This is new screening. Okay. Can I solve the next one?
Yes, just a second. I will give you the evidence from the chart.
But if, sir, it is a borderline, I will repeat the HPV
6 months,
if inadequate.
Yes, 6 months, my dear. I will give you the answer here. This is the answer of the question. If the woman have low-grade dyskaryosis with inadequate colposcopy, but if borderline with inadequate, this is a difference, and this question always coming in the exam. If the woman have low-grade dyskaryosis with inadequate, go for colposcopy. Woman have okay.
Okay, doctor. Okay, I get it.
You can repeat it, please.
If the woman have low-grade dyskaryosis with inadequate human papillomavirus, she have finding. Refer her for colposcopy. If the woman have both borderline and inadequate, now you will repeat after 6 months, and this is the only situation to repeat after 6 months. Always we are repeating after 3 months. If inadequate cytology or inadequate human papillomavirus, you are repeating after 3 months. But if you find borderline or human papillomavirus inadequate, you will go for repeat after 6 months. Repeat what? You repeat both. human papillomavirus and cytology. Okay. This is always coming an exam trick. Low-grade dyskaryosis with inadequate, go for colposcopy. Borderline, repeat after 6 months. Let's go for the question. Question number 11, 12. Okay, question number 12. Dr. Danzig or Dr. Nazik? Okay, Dr. Nazik, would you like to share?
Yes, Dr. Hani. A 30-year-old woman undergoes colposcopic treatment for cervical intraepithelial neoplasia, CGIN. Histology shows incomplete excision at the ectocervical margin, but complete excision at the endocervical margin. This is incompletely excised CGIN.
Again, so think about 30 years, CIN3, incomplete excise, no CGIN, no invasion. What you will do?
HPV?
My dear, this is unclear margin.
She's candidate for relits.
No discharge.
This patient should be discharged for the test of cure in the community. Criteria is met. Less than 50, no CGIN, and no invasion. So test of cure in the community after 6 months. Okay. Human papillomavirus test of cure after 6 months. Question number 13. After Dr. Nazik, one with doctor only, if you would like to share.
Yes, sir.
Yes.
31 years old, completes treatment for CIN1. She asks what she's next need to check up. HPV test of cure after 6 months.
Yes, so if the patient have a treatment, the next step will be test. Yes, if test of cure is negative.
If test of cure is negative, we will send her for routine after 3 years.
No, my dear, I told you, if treated, no routine, 3 years.
Yes, okay.
You did a treatment, no routine recall. If you did a treatment, no routine recall. 3 years recall. If the test of cure came negative after 6 months, 3 years recall. Okay?
Okay. And if not treated, I will repeat after 12 months.
After 6 months. Test of cure after 6 months.
I mean if not treated.
If treated, you will go for test of cure. If untreated, yearly follow-up, not test of cure. Cervical cytology, okay?
Yearly for how long?
Yearly follow-up until the patient regress or progress.
Okay, thank you.
The questions before this human papillomavirus test of cure?
Test of cure, yes. Test of cure after 6 months.
By human papillomavirus? Okay.
Both of them, cytology and human papillomavirus. Dr. Abir. Dr. Abir. Dr. Anas. Don't lose your time or lose others' time. Try to answer or say I will not answer. Dr. Benita Banshal.
Hello.
Yes, my friend. Go on, please.
The answer is advised 5 yearly smear.
Read the question first, please.
51-year-old has recently moved to UK from Australia. She advises she had a normal smear 4 weeks ago, just before leaving Australia, but wonders if and when a further test is required.
So the answer will be
5-yearly smear.
Why? Routine recall after 50.
Routine, yeah.
Routine recall after 50. Thank you. Question number 15. Who is next? Dr. Iyaz.
For the scenario below, choose the most appropriate management option from the list above. You are contacted by a local GP. 28-year-old woman has turned up for a routine cervical smear, as it is now 3 years since her previous one. The GP had noticed a bump, and patient confirmed that she is around 16 weeks pregnant. So we will do smear at 28 weeks. There is no option.
This is a routine recall during pregnancy. What you will do?
After 3 months after delivery?
Yes, you will do it 3 months after 12 weeks postnatal. This one, because it is a routine recall during pregnancy. Defer it after pregnancy. Okay.
Okay. Thank you, sir.
What is meant by bump, sir?
Pregnant, my dear. She's pregnant, have a bump in her abdomen. So she's now 16 weeks pregnancy. For routine recall should be...
Bump means what? Yani, her abdomen is enlarged?
Yes, my dear. Her tummy have like a bump. There is a mass. And he asked her, so after pregnancy...
Thank you, sir. Thank you.
Question number 16. Dr. Lata Duta. Dr. Lata, if you like to share. Dr. Maliha. Dr. Maliha. Dr. Mariam.
Assalamu alaikum, sir. 34-year-old patient has had successful surgery for breast cancer, but has been taking tamoxifen for the past year. Her last smear was 12 months ago, around the time of diagnosis. So, sir, after advice smear in 24 months, routine recall.
Yes. Is tamoxifen indication to change the cervical screening? Is tamoxifen have any issue on the cervical screening?
No, sir, I don't think so.
No. No, sir. No.
No, sir.
It's affecting only the endometrial thickness, so it causes endometrial hyperplasia, but not changing the routine screening. So this patient have cervical screening since 1 year, so it will be advised her due screening after 24 months, means the routine recall. You will only do HIV or additional screening. If HIV, it will be annual screening. End-stage renal failure, screen at the diagnosis. If the woman have renal transplant within 1 year of the transplant, starting any cytotoxic rheumatology drug, screen at starting the treatment. Tamoxifen therapy is not indication for additional screening, and the patient should be in the routine recall. Okay. Who is next? Dr. Niamat Anisu.
Yes, number 17, a 26-year-old patient attends for her first cervical smear. The GP cannot visualize the cervix and has asked for your advice. Since we cannot see, I think we should refer for colposcopy.
Yes, if you cannot visualize the cervix, send the patient for colposcopy. Patient with cervical stenosis, this should be whose cervix is not possible to visualize, should be referred to colposcopy. Okay. Thank you, Dr. Naamat. Question number 15.
Sir, can you just clarify in the options if there is HPV triage instead of colposcopy, then can we do HPV triage or it should be colposcopy only?
This is written in the details of the NHS cervical screening program. If you couldn't take the sample or you couldn't visualize the cervix, refer the patient for colposcopy. Okay, if you have cervical stenosis, you can tell the patient to try to take the smear in her due date or refer for colposcopy, or if she wishes to withdraw. This is written in the details of the NHS cervical screening program. Okay?
Thank you, sir.
18, question number 18, after Dr. Naamat, Dr. Ras, RAS, Dr. Ras, Dr. Rima, Dr. Rima, Dr.
45.
Okay.
Yeah, a 45-year-old undergoes loop excision due to diagnosis of CIN3. CIN3 is evident on the lateral excision margin. What is the appropriate management?
Again, unclear margin.
Yeah, so we will do LEDs.
Why?
No discharge.
This patient is 45.
Discharge from country.
CGIN. So discharge for test of cure after 6 months. If the patient have no evidence of glandular abnormality, no invasive disease, and or the age is less than 50, don't repeat leads. Unclear margin, even so, don't repeat leads. 19.
Okay. Thank you.
Welcome.
Dr. Hani?
Yes.
Please, sorry for interruption. After finishing the mock, would you clarify for us the SIM3 excision? Because this area, I think, most of us confused into it.
No problem,
after finishing
after
the mock, if you don't mind.
Stop the recording and feel free to ask any question.
Thank you.
Who's next? Shukrat, my friend. Are you free?
Okay. An 18-year-old woman presents with 4-month history of postcoital intermenstrual bleeding. She has been using the combined oral contraceptive pill for 3 years. Our 26-year-old sister has just completed treatment for a squamous cell cervical cancer. On examination, the cervix displays a prominent cervical ectropion. Screening for sexually transmitted infection is negative. So what is the most appropriate course of action? A cervical smear test, an urgent referral for colposcopy, a cautery of the cervical ectropion, cervical biopsy, reassurance that she does not have cancer.
Reassurance.
She just presents with 4 months history of postcoital. She has been using the combined oral. So because she has been on combined oral contraceptive pill, then we don't do anything for her now. So you reassure her, because if you want to test her, it will be after 3 months of stopping the drug, I think.
Just extropium from the combined oral contraceptive. This is no need for any indication. Just reassure the patient that she don't have a cancer. Question number 20. Dr. SK, Dr. Sakina or Dr. SK.
Excuse me, Dr. Hani, we will not treat the ectropion. We will not do for cautery for her.
No, my dear, just reassure the hair that she don't have.
Obsolete. Ectropion cautery is obsolete now.
No, we don't treat ectropion.
Just medical treatment. Keep discussion at the end, please. Don't interrupt your colleague. Go on, Dr. SK. Dr. SK. Dr. Paco.
30-year-old woman presents to colposcopy clinic having had a cervical smear showing low-grade dyskaryosis and possibility for high-risk HPV infection. She has no relevant past medical history. She has a family history of her maternal aunt and grandmother both dying from cervical cancer. She smokes cigarettes, 10 cigarettes per day, and has recently broken up with her partner. Her children are aged 13, 6, and 2 years old. Her BMI is 36. She has a period and no postcoital bleeding and no vaginal discharge. She's on Depo-Provera for contraception. What is the more appropriate advice regarding her management? Okay, have a colposcopy and biopsy of any abnormality revealed. Have a colposcopy, and if abnormality are seen, have a repeat cervical smear at that point. Have a cervical biopsy only. Have a hysterectomy if a family is complete. Have an excision biopsy and less or other technique. I think the answer is A. Have a colposcopy and biopsy of abnormality revealed.
Yes, excellent. The answer is A, having colposcopy and biopsy if any abnormalities is revealed. Excellent. Who is next? Dr. Suzanne Ibrahim.
Yes. Yes.
21.
A 24-year-old woman has multiple biopsies of her cervix at the colposcopy clinic due to high-grade dyskaryosis. Histology shows CIN3 with areas of microinvasion. What is the most appropriate advice regarding her management? High-grade dyskaryosis and CIN3 with areas of microinvasion. Have an excisional biopsy using leads.
Yes. If she have microinvasion, I will go to repeat leads. Okay.
Okay.
Next. Dr. Ibtihal. Dr. Ibtihal. Dr. Iman. Dr. Fadwa.
Yes,
Go on, please.
yeah, 35 years old smoker is diagnosed to have mild dyskaryosis, and her index smear at the GB cell as well. Okay, the smear is HPV negative. What is ideal management? She's 25 years, smoker, diagnosed to have mild dyskaryosis and HPV negative, so she will go for the routine recall.
Yes. What is her routine recall? Pick an answer.
Every 3 years, yeah?
Yes, because she is less than 25.
Yes.
So the answer will be A.
Yes.
Answer will be A. Reassure and discharge for repeat smear every 3 years. This means the routine recall. Okay, a lot of option. Who's next? Dr. Fadwa was the last one. Who's next after Dr. Fadwa? Dr. Fatima. Dr. Fatima or Dr. Fatima?
Yes, Dr. Hani.
Sorry for that. Just a second, please. Just a second. There is no animation. Just a second. I will give you the question now.
Okay.
Okay. So this was the last question, and this is the option. This is a question. 23.
Okay, a 40 years old woman attend the gynecology clinic with a history of leakage of urine on coughing or sneezing following the birth of her last child 2 years ago. A urine dipstick is negative. A decision is made to commence a course of supervised pelvic floor muscle training. She is having stress incontinence and advised to do supervised pelvic floor muscle training. Okay, what is the question?
What is the next step for each of the following scenario? What is the most appropriate investigation that need to be performed before any therapy is commenced? Each option can be used once. What is the next step? The patient now have 40 years, is a 40 years old, attends for the gynae clinical with a history, with a history of leaking of urine, coughing or sneezing, so stress, urinary incontinence, clinical
incontinence, yes.
2 years, they exclude urine dipstick negative, exclude no urinary tract infection. A decision made to do pelvic floor muscle exercise. What you
yes. What?
What is the next step? What you will do?
I will follow her after 3 months. Follow up after 3 months after pelvic floor muscle exercise.
You need to assess her first to give her an option of pelvic floor muscle exercise. Simply, you will do digital assessment of the pelvic floor muscle contraction. Okay? If you have a woman with prolapse, you should examine her, do digital assessment, exclude urine dipstick or exclude infection, and assess her if you need urodynamic or no. There is no indication to do urodynamic unless a patient has stress urinary incontinence with mixed symptoms. These are the indication of urodynamic. Mixed symptoms, apical or anterior wall prolapse, apical or anterior wall prolapse, you will do urodynamic a previous surgery. So stress urinary incontinence is a clinical diagnosis. You will not do urodynamic unless there is one of these. Make sense?
Okay.
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 So first, urinary tract infection, do pelvic assessment, then refer the patient for pelvic or physiotherapy.
Okay.
Or (24) after دكتورة فاطمة دكتور جيسا راني دكتور هاجر دكتور هالة مصطفى
55 years old woman who previously had insertion of tension-free vaginal tape for the treatment of stress incontinence. She attended with new symptoms of urinary leakage with physical exertion on coughing. She is requesting further surgery. Before further surgery, she is having previous surgery, so we'll do urodynamic.
So this is one of the indication to do urodynamic for stress urinary incontinence. If the patient have a previous surgery, I will do urodynamic. Filling and voiding cystometry is a urodynamic. Okay?
Okay.
Excellent, my friend. Thank you, Dr. Hala. Next, after Dr. Hala, Hamida, Dr. Hamida.
Yes. A 60-year-old woman has initial appointment at the gynecology clinic. Her presenting symptoms are urinary leakage, urgency, and nocturia.
She's just presenting symptoms to the clinic. What you will do?
Urine dipstick?
Yes, exclude urinary tract infection.
Yes.
I will do urine dipstick to exclude urinary tract infection.
Okay, thank you.
Unremarkable or undertake a urine dipstick in all women presenting with any urinary incontinence to detect if there is any urinary tract infection, any glucose, any protein, any leukocyte, nitrite in urine. So exclude urinary tract infection, do pelvic assessment, think for the criteria, is there is indication for urodynamic or no. This is, I didn't hide. Sorry for this.
Sir, in this case, is this not bladder diary before urine dipstick?
Exclude first
Previous
urinary tract
question.
infection. Yes. Exclude first the urinary tract infection, then do the investigation. I'm very sorry because there is some slides without hiding. Give me a second. I will review all the remaining questions. Don't lose your time. I'm very sorry for that because I collected the question just today to make a mock exam after the session. Okay. So 27, we answered this one. 26. Who's next? Dr. Hanin, you are next.
Yes. A 60-year-old woman returned to the urology clinic for a review. She initially presented with symptoms of urinary leaking and urgency. She has completed the course of bladder training with no effect. She has myasthenia gravis, but is otherwise well. So for drugs, but we will avoid the drugs that contraindicate with myasthenia.
What is the drugs which contraindicated with myasthenia? All the anticholinergic drugs, which is the first line, is contraindicated with myasthenia. So what you will give her?
What is the options?
What is the second line after that? The woman have urinary urgency.
Mirabegron?
Mirabegron, yes. The second line is mirabegron. Because the first line is contraindicated, or the anticholinergic drugs or the antimuscarinic drugs are contraindicated or clinically ineffective or have unacceptable side effects or contraindicated, like in this situation, in myasthenia gravis, you will go for mirabegron. Okay. 27. Next. Dr. Hinna Aftab.
A 55-year-old woman initially presented with urinary leakage on coughing and sneezing. She completed a course of pelvic floor muscle training with little effect. She wishes to avoid surgical intervention. So we will give duloxetine to her.
Yes,
because she's refusing surgery.
Duloxetine is not the first line. Even it is not the second line. but only offered in this situation. If the patient have no benefit from the pelvic floor muscle exercise for stress urinary incontinence and don't want a surgeon. So the first option, pelvic floor muscle exercise or pelvic floor muscle training. The second option is the surgery, colpo suspension or fascial autologous slings. And the third option will be duloxetine if the woman is unfit for surgery or refuse surgery. In this situation, I will offer duloxetine. Excellent. 28. Who's next? Dr. Hind.
Yes, Dr. Han. A 62 years old woman who is otherwise fit and well, present with urgency, urinary leakage, and nocturia. The urgency and leakage are improved with transdermal oxybutynin, but the nocturia remains troublesome, with her needing to go to the toilet 4 or 5 times per night. This desmopressin, what was that one? For nocturia. Yeah,
Dr. Hind. Who's next? After Dr. Hind, Dr. Kanshan, sorry for the pronunciation. Dr. Kanshan.
Yes.
You are very lucky. The POPQ. Please make me happy.
A patient presents with symptoms of prolapse. On examination, the pelvic organ quantification score is AA0, BA0, C minus 5.
AA0, it's in place?
No, it is not in place.
It should be -3.
Yeah.
And BA0, it is in place?
It is also not in place.
So it should be higher than -3, -4, 5, or 6. So it is also descent. C, it is in place?
No, it is a slight descent.
Slightly descent. D is in place?
It is also slightly descended.
B posteriorly or point A posteriorly is in place?
Slightly below.
Excellent. It should be -3. It is -2.
-3, -2. Yeah.
Point B by posteriorly is in place?
No, it is also descent.
It's also descent. So the total vaginal length is good. The genital hiatus is dilated,
it is
and the
enlarged.
perineal body is normal. So what is this stage?
Stage.
If I draw it, it will be like this. At 0, here.
Stage 2.
And yes, and the posterior wall is for some while in place. This is point A anteriorly and point B anteriorly. Post point will be here at 0. Yes, it's stage 2. Stage 2 what?
Stage 2. No, it is stage 2 cystocele.
And the treatment will be?
Anterior repair.
So this is the answer. It's a stage 2 because the prolapsed part at the level of 0, 1 centimeter above or below, it will be stage 2. So this prolapsed part is stage 2 from the anterior wall, because all the point of the anterior wall is prolapsed, but the point of the posterior wall it's still in place. So mainly anterior wall prolapse. It is stage 2. Cystocele needs anterior wall prolapse. Does it make sense?
Yes.
Excellent, my dear. And this is the exam question.
Please repeat again.
After the recording, I will repeat it. Another question is coming here. Who's next? After Dr. Kanshan, KMM, would you like to answer this question?
Can I answer the
Dr.
question?
Okay, go on.
Okay. A woman presents with the symptoms of prolapse. On examination, the pelvic organ quantification score, POPQ,
is AA minus 2, slightly descend, slightly. BA minus 2, slightly descend. C minus 5, slightly also. D minus 7, slightly as well. AP, the posterior vaginal wall, it's 0. That means it's in the hymen level. CGL 9, the same level of total vaginal length. The genital hiatus, it's 4, slightly distended. The perineal body 3. So this is a posterior. This is a stage 2 rectocele. It's need posterior repair.
Excellent. So this is a stage 2 rectocele needs a posterior repair. This is the answer.
Thank you, doctor, for making it easy, very easy.
Thank you very much. It's a toy now. We are playing with the urodynamic. We are playing with the POP-Q. It will be a toys in the exam. Question number 31. Who's next? Dr. Lenovo. Someone enters by his mobile name, Lenovo. If would like to share. Dr. Muhammad Mustafa or M. Mustafa. If you would like to share. Mahmoud, Dr. Mahmoud. Dr. Mahmoud. Marvi. Marvi. Cannot share.
Dr. Khani, can I share?
Sure. Go on, Dr. Reshmi.
Question number 31. With regard to squamous cell carcinoma of the cervix, what is believed to be the minimum time span between the infection by HPV and the development of a pre-malignant lesion with the true malignant potential? Is it 7 years?
Yes, 7 years. And this is why they want to go for the HPV. 7 years is believed to be the minimum time span between infection by human papillomavirus. Question, a lot of option. Again, cervical screening. 32. Marwa.
Yes, Dr. Henry. A 28 years old woman attended her GB routine cervical smear examination is difficult and inadequate. So colposcopy. This repeated question, Dr. Henry.
This is a repeated question?
Yes, colposcopy needed, yes.
No, she have inadequate. Now she have inadequate result.
Difficult or inadequate? The examination is difficult. Ah, okay. And the inadequate. This one. She will repeat. She will repeat. She will repeat after 3 months. But here, I know that 3 months.
Yes.
No, 3 months.
Yes. Sorry for this question. If it is difficult to find the cervix, it will be colposcopy. But if inadequate, it will be repeat after 3 months. Another question, Marwa, because
this question. Okay. A 35 years old attend to her GB cervical smear having never had smear in the past. High grade dyskaryosis. Okay, this is for colposcopy without HPV. No need for HPV.
Excellent, my dear. If you didn't score 90%, Marwa, I will kill you.
خلاص, kill me from now, doctor. Kill me now.
Dr. Mawahib. Thank you, Dr. Marwa. Dr. Mawahib.
Yes.
My friend. 34.
A 31-year-old woman attends her GP surgery for a cervical smear. This is reported as a low-grade dyskaryosis and HPV test is organized. Unfortunately, the HPV test is inadequate. Low-grade and inadequate HPV for the colposcopy.
Yes, if she have, this is a repeated question also. If she have low grade with inadequate HPV, it will be for colposcopy.
Yeah, repeated question.
I think also this is a repeated question. Okay. Endometrial hyperplasia. Who's next after Mawahib? Madiha, Dr. Madiha. Thank you, Dr. Mawahib. Dr. Madiha, would you like to share? Okay. Go on, please. 36. Almost we have only 5 questions more.
A 54-year-old lady presents with a postmenopausal bleeding. The pupil biopsy shows endometrial hyperplasia without atypia. She declines to have a coil. 54 years without atypia. Marina.
Marina by the lay language. She don't want a coil.
Oral progestogens.
For 6 months.
Hysterectomy.
So she will take continuous oral progestogen for 6 months.
6 months. Okay.
So who's next? Dr. Mona. 37.
37, 43 years old, para-2 lady, has body mass index of 46. She complains of menorrhagia and the pupil biopsy shows endometrial hyperplasia without atypia. She had merino coil inserted 2 years ago, but the symptoms have recurred. So we will try second line with her, this progestins.
Why?
Because she used merino before.
She used Mirena, my dear, but no regression. It's a 43 years old woman, and BMI is 46. Pupil biopsy showing without atypia. Mirena now for 2 years, but no improvement, and the symptoms recur. So you will go for hysterectomy. But
Hysterectomy and bilateral salpingectomy. Huh?
Yes, you will not remove the ovary. That's why I bring this question. In a perimenopausal woman, keep the ovary, please. Okay? So this woman will be total laparoscopic hysterectomy with conservation of the ovary. That's the trick in the guideline. Okay?
Dr. Hani, this if she is below 55 years.
If it is perimenopausal woman, yes. If it is perimenopausal woman and she have endometrial hyperplasia even with atypia, remove the uterus and the tubes and leave the. Okay.
Yes, thank you very much.
Dr. Hani, till what age we can conserve the ovaries? Any age limit?
Perimenopausal only. Perimenopausal only. Not in postmenopausal woman.
51.
Biopsy in case of progress.
In postmenopausal woman, remove the ovary. The risk of concomitant cancer of ovarian in postmenopausal woman up to 5%, 4 to 5%. So you remove the ovary. Who's next? We're almost finished. I know that you want to run. Dr. Amuna Muhammad.
Doctor, can I share?
Sure.
Can
I
share, Dr. Hani? 42 years old, para-3 woman is diagnosed with endometrial hyperplasia with atypia. She had oral progesterone therapy. Her follow-up endometrial pupil biopsy at 12 months shows endometrial hyperplasia without atypia. It's persistent, so we will do hysterectomy with preserved ovary.
Again, I bring this question for that. Excellent, my dear. So laparoscopic, always choose hysterectomy, remove the uterus and the tube, and conserve the ovary. Okay. Who's next?
Sir, I'm sorry, sir, but it regress. It with atypia and then it is without atypia. Isn't it a regression?
Yeah, regression.
Even so, it will be a persistent hyperplasia even without atypia. This is a distractor. A distractor. Take care about the RSOG people.
Yes. Persistent hyperplasia.
Yeah.
39. Dr. Murad.
A 49-year-old lady complained of menorrhagia and was found to have endometrial hyperplasia without atypia 2 years ago. She had the Mirena coil at the time. She had 2 pipal biopsies 6 months apart and they were normal. Discharge to routine.
Excellent. So this patient have endometrial hyperplasia without atypia, and she did 2 consecutive negative sample, and she have no risk factor. She have body mass index not 35 or more, and she have Mirena, not progesterone. So I will discharge her. Excellent.
Thank you.
Welcome. Next after Dr. Murad. متوكل ايه؟ If you would like to share. Dr. Nahid Ali. Okay.
Can I share, Dr. Hani?
Okay, go on. These are the last question, I think, or last 2 questions.
A 39-year-old mellitus lady complained of menorrhagia. She is found to have endometrial hyperplasia without atypia. She wants to conceive soon. So we can insert Mirena for her. And if she has 1 negative biopsy after the Mirena, she can be referred to fertility center.
I will give a clue here, my dear. She is 39 years old, nulliparous ready, complains of menorrhagia. She is found to have endometrial hyperplasia with atypia. She wants to conserve soon. Even if Mirena is the first line, but in this patient, I will give her oral progesterone. Why? Oral progesterone and endometrial surveillance every 3 months should be given. They should have progesterone therapy and repeat biopsy at 3 months, which should be negative period to conceiving, because she wants to get pregnant soon. If I put Mirena, it will take time and delay the pregnancy. So if he give you a clue here, give a progesterone continuous therapy, okay?
Okay.
Excuse me, Dr. Hani, for all patients who want to conceive, what I understand before, we have to follow them up after 3 months, like this patient, and then we send them for with atypia, we send them for the fertility clinic. So, why for them we said Mirena, and why for this patient? Because all of them we need 3 months, 1 follow-up negative, then we will go send for the fertility. So why here like this?
The first line of treatment to put a Mirena. If the woman wants to get pregnant so soon, she is 39 years old, losing her fertility, and wants to conceive, I will give her progesterone and I will follow up her 3 months. If negative, I will refer her for fertility. Okay?
But for all patients, we are doing the same, right? For all patients who want to fertility, like this, after 3 months, we refer them, even if they don't want soon.
Even as Mirena is the first line, but she wants to get pregnant, so give her oral progesterone.
So, Dr. Hani, can I ask a question? So, if she's younger, if she's like 25 years, we can insert the Mirena before she can conceive, or it is a rule for all the ages?
The Mirena is the first line and will give a better chances to, you will counsel her that Mirena is the first line and will give you a better chances to regress, but it will delay the pregnancy. If she want to get pregnant soon, give her progesterone, and you will tell her that progesterone is the second line counseling. Mirena is the first line, better chances for regression, but you will not get pregnant until we remove the Mirena. So she will lose a time. Mirena and removal of the Mirena and getting pregnancy. So progesterone is a better option. Who will catch the last question? Last one.
Can I, Doctor?
Yes, Doctor.
56-year-old
on tamoxifen. Complaints of postmenopausal bleeding. She is found to have multiple polyps on transvaginal scan, and the endometrial polyp shows endometrial hyperplasia without atypia of 56.
A 56 years old woman on tamoxifen complains of postmenopausal bleeding, and she found that multiple polyps on transvaginal scan. Endometrial biopsy saw endometrial hyperplasia without atypia. What you will do?
Marina?
Hysterectomy?
The first line is Myrene. In postmenopausal, the first line for endometrial hyperplasia without atypia is Myrene. Hysterectomy is an operation.
Yes,
it is not indicated.
In
tamoxifen.
Myrena, is it indicated?
Why we can't do here
we can go
hysteroscopy and endometrial biopsy?
She already done, and she have endometrial hyperplasia without atypia. So why hysterectomy? Myrene is the first line.
Sir, what about polyps? Multiple polyps.
Polyps from the tamoxifen, my dear. Tamoxifen increasing the endometrial thickness. That was the last trick today. I hope that you enjoy my magic or the session.
Okay,
Dr.
Dr.
This
is tamoxifen not due to see a breast. Will not give Myrena.
Dr. Hani, how to differentiate the
unless
anterior
multidisciplinary
prolapse and posterior prolapse?
Will put Myrena or no? A multidisciplinary team who will decide. This is an issue about breast cancer and tamoxifen and the patient for Myrena.
Dr. Hani, if there is in the answer, refer here to change the tamoxifen or for an alternative. Is it it will be the choice?
This is written in the details of the guideline. Review the indication of tamoxifen, and after that, if you can change the tamoxifen and put a Myrena to protect the patient. It's a decision, multidisciplinary team decision. I hope that you enjoy the session. This is my past list in the last course. I hope you will join them soon, and best of luck.
Dr.
Thank
you.
Doctor, I have
Thank you so much, sir. But one question is that what we have to follow in survival rates of cancer?